Good evening, sir.
Good evening. In
Good evening, sir.
good evening, Chandni ji. Good evening.
Should I start?
हाँ अभी अपन तैयार हैं बिल्कुल बिल्कुल है ना?
Thank you. Good evening, everyone. Welcome all the delegates. Today we are here with our next session from the series Bowel Ultrasound Master Course. Let's welcome our today's speaker, Dr. Subhash Taylor, sir. Sir is Chief Radiologist at Haryana Hospital, Bhilwara, Rajasthan. Sir has a special interest in ultrasound and color Doppler, especially in bowel and small parts as well as in MSK ultrasound. Without taking more time, I hand over the session to Dr. Subhash. Over to you.
Thank you, Chandni. Welcome everyone this evening. I'm Dr. Subhash Taylor, Chief Radiologist, Haryana Hospital, Bhilwara, Rajasthan, India. Today I'm going to discuss about role of ultrasound in bowel infections, inflammations, and tumor-like conditions. And we will first understand the clinical scenario and the clinical symptomatology related to these, various pathologies related to infection, inflammation, and tumor-like lesions, tumor and tumor-like lesions. So just before starting, we must understand the symptomatology in infective inflammatory bowel diseases. Now, most of the signs and symptoms are overlapping, means common in various pathologies, though the underlying cause is different, right? From infection to autoimmune mediated inflammatory lesions to neoplastic benign or malignant pathologies. Abdominal pain is a major symptom by these patients. Pain is often colicky in infective pathologies. Crampy or chronic in inflammatory bowel disease, and localized pain is appreciated, particularly in appendicitis, that is tenderness in right iliac fossa, pain and tenderness, diverticulitis, and epipleural appendicitis. These pathologies usually cause localized pain at all. Loose motions or diarrhea is another important symptom. In infective conditions, there is usually history of acute onset of diarrhea, which is often watery or bloody. In inflammatory conditions, diarrhea can be recurrent or chronic and may be bloody. Blood stains, stool is passed in cases of ulcerative colitis. Fever is common in both infective and inflammatory pathologies. More prominent in infections like Salmonella, Shigella, or in abscess forming, or when the IBD is complicated by infections, and when abscess is present, then fever is usually present along with the inflammatory bowel disease. Weight loss is again there. It is common in inflammatory bowel disease due to malabsorption and catabolic state, and it is rare in acute infections. Fatigue and malaise being systemic response to infection or inflammation. Rectal bleeding, very important symptom in cases of infective colitis. When colon is involved by infective pathology or by ulcerative colitis, that is inflammatory pathology, rectal bleeding is an important symptom. So rectal bleeding is seen in infection, ulcerative colitis, Crohn's when the colon is involved, and ischemic colitis. Now, mucus in stool is suggestive of colonic involvement, like ulcerative colitis, bacterial colitis, or dysentery, amoebic dysentery. Tenesmus is a symptom of incomplete evacuation of the rectum, commonly seen in rectal inflammatory conditions, that is ulcerative colitis and proctitis. Nausea and vomitings are again a symptom which is seen in severe infections or small bowel involvement like Crohn's, gastroenteritis, and gastroenteritis conditions. Additional clues by conditions: when patient is suffering from gastroenteritis, The etiology can be viral, bacterial. There is sudden onset of diarrhea, vomiting, fever, and dehydration. In amoebiasis, there is gradual onset of diarrhea or dysentery, and fever and pain abdomen is seen when there is possible liver abscess. In Crohn's disease, perianal disease can be present as perianal disease. We see skip lesions. There is issue of weight loss, small bowel obstruction sometimes. In ulcerative colitis, bloody diarrhea, it is left-sided abdominal pain, and there is urgency for defecation. In diverticulitis, most commonly affect the left-sided colon, sigmoid and descending colon, causing left-lower quadrant pain, fever, change in bowel habits. Appendicitis, again, initially there can be epigastric or periumbilical pain, which shifts to right lower quadrant with pain and tenderness in right iliac fossa. There can be nausea and rebound tenderness present. So these are the common, the signs and symptoms related to various pathologies. Now, common infective and inflammatory pathologies. Inflammatory bowel disease, most common, there are two important conditions, that is Crohn's ileitis or Crohn's disease and ulcerative colitis. In infective ileocolitis, etiology is viral and bacterial. Sometimes we can see parasitic infestations. And now Schönlein purpura is basically a immune-mediated vasculitis, which is seen in pediatric and young adults. Another important entities and pathologies are Koch's abdomen and ileocecal tuberculosis. Of course, it is a chronic infective pathology. Appendicitis, Meckel's diverticulitis, colonic diverticulitis, peptic or duodenal, peptic ulcer disease involving gastric ulcer or duodenal ulcer. Duodenum is more commonly involved. Mesenteric lymphadenitis. So these are various pathologies today we are going to discuss. Now coming to salient features of Crohn's, ileitis, there is circumferential mural thickening of the terminal ileum, including IC junction and part of cecum and ascending colon, with less affection of cecum. Mural thickening is more than 3 mm in small bowel and more than 4 mm in large bowel. So this is a standard, criteria that if it is less than 3 mm in small bowel, it is normal limit, and less than 4 cm is normal limit for large bowel. So when it is thickness is beyond 3 or 4 cm in respectively in small and large bowel, it is suggestive of bowel wall thickening. We will see some areas, normal areas within the bowel in Crohn's disease. So skip lesions are a salient features of Crohn's disease along with wall thickening. There is abrogation or loss or alteration or blurring of the mural stratification or the gut signature or the gut layer. Very important feature. Mural rigidity. That means the bowel becomes non-compressible and akinetic or very poorly peristaltic, so causing subacute obstruction. And elastography is helpful in assessment of the mural rigidity. Bowel wall hyperemia, suggestive of active disease. We can see comb sign in the adjacent mesentery because of the infiltration of the mesentery, and there is hyperemia because of the vasa recta passes through to supply the bowel. They becomes prominent and give a comb sign in ultrasound like that of your CT scan. So we must observe and mention the Limburg scoring. Peri-entry fat reaction is a cardinal sign of Crohn's disease. It is because of fibrofatty tissue thickening, because of the active inflammation, because of the edema and infiltration by the inflammatory cells. So the adjacent mesentery becomes thick and aquagenic. Segmental luminal narrowing with proximal fullness. The segment involved will show, akinesia or stagnancy. So there is proximal fullness. Mesenteric abscess and fistula formation as a complication. We see as a complication in Crohn's disease. Transmural inflammation is also lead to ascites and mesenteric nodes. Transmural spread of inflammation is through when the infection passes from mucosa to submucosa to muscularis propria and serosa. This is how the disease process proceeds, leading to serosa, and then there is involvement of the parietal peritoneum, leading to ascites and mesenteric lymphadenopathy in response to infection and inflammation. Doppler assessment of superior mesenteric artery and inferior mesenteric artery is also performed in Crohn's disease. In active disease, there is high impedance and high volume of flow, and in assessment of the response of the treatment. In chronic cases of Crohn's ileitis, there is usually healing with fibrosis. So there is stricture formation of the bowel loop, leading to proximal fullness and dilatation. So these are salient points of Crohn's ileitis, what we see on ultrasound. So we must remember these important points. Now, before going further, we must understand the Limburg scoring. Basically, this Limburg score is semi-quantitative blood Doppler ultrasound assessment of bowel wall vascularity, particularly in inflammatory bowel diseases. There are various grades from grade 0 to grade 4. Grade 0 means normal bowel with no thickening, well delineated mural stratification, no blood flow appreciated occurring. That is grade 0, means normal bowel. Grade 1 means there is bowel wall thickening, but the blood flow is not much. There is absent blood. Only thickening is there. That is grade 1. Grade 2, there is hypoflow, wall thickening with intermittent or spots, suggestive of increase in vascularity. Grade 3, hyperflow, wall thickening with protracted stretches of the increased vascularity. Here there are spots, there are protracted stretches of the blood flow channels. Grade 4 is hyperflow. Color Doppler flow signals both in the wall and surrounding fatty tissue, surrounding the set. This is grade 4. So increased vascularization, that is Limburg score 2 and above, is considered abnormal. Grade 0 to 1 are not very significant. So coming to case illustrations. So here 22 years male with crampy abdominal pain. You can see dilated bowel loop, small bowel loop. It is ilean loop. We follow it. There is segment, there is fairly long segment narrowing. Again, normal. So this is a segment of the small bowel, that is ileum, showing concentric hypoechoic wall thickening with slightly altered, layer pattern, luminal narrowing with proximal dilatation. This is what, and this is on color Doppler. This is a target-like appearance of the affected segment, concentric thickening, luminal narrowing. On Doppler, we can see hypervascularity of the bowel wall in transverse as well as in the longitudinal plane. And there is proximal dilatation because this particular segment is showing stricture formation. Stricture means there is luminal narrowing. So there is proximal dilatation causing symptoms of pain, abdomen, and vomiting. So this is a case of acute Crohn's colitis. Another case, male, 28 years. This is right lower quadrant high resolution scan. You can see normal loop. Now the abdominal bowel loop in transverse plane with loss of gut signature. This is again normal bowel. Normal dilatation, there is thickening, gut signature loss, there is marked fat reaction. This is a short segmental iliitis. So this is a proximal normal portion. This is thickened with loss of a gut signature and marked transmural spread of the inflammation leading to mesenteric thickening, which is known as echogenic mesentery sign, echogenic mass effect, thyroid sign, inflamed fat, whatever you call it. So when we see on elastogram, so this particular segment is seen hard on elastogram. W is hard in this. So this becomes more hard, non-compressible, and poorly kinetic. We may also see sometimes lymph nodes and mild amount of the free fluid in peritoneal cavity. And again, on microvascular flow, we will see tremendous vascularity within the bowel. So again, a case of acute Crohn's ilitis. Another male, 30 years, we can see a target-like concentric thickening, prominent submucosal layer. This is mucosa. This is muscularis propria. This is serosa. Gut signature is preserved right now. There is mural hyperemia. Again, when we apply elastography, we can see this red is hard here. So there is, the wall becomes, particularly the submucosa becomes stiff. So in Crohn's ilitis, we always see, comb sign. So when there is transmural spread of the inflammation or inflammation to the mesentery side, there is thickening of the mesentery. And through the mesentery, we can see the vessels are entering, vasa recta entering. So these vessels become more conspicuous. And we will see a comb sign like that. So on longitudinal plane, we can see the mesentery is thickened with hypoechoic channels. These are nothing but prominent arterioles entering to the bowel, giving a typical, appearance or typical comb sign in the background of fatty infiltration. So this is how we identify the comb sign in cases of Crohn's ilitis. It is because of mesenteritis leading to prominence of these vasa recta. Now, in this patient, in fact, the transmural inflammation has spread beyond serosa and there is focal small abscess formation in the mesentery. So this is again a complicated case of Crohn's ilitis leading to small mesenteric abscess. And in this case, we see a fistula formation. And in another segment of the same case, these are images of same case, we can see fistula formation between two bowel loops. This is one bowel loop and this is another bowel loop, there is fistula formation. So fistula formation can be into the adjacent bowel or in the adjacent colon, or we can see fistula formation in urinary bladder or in vagina in cases of rectal Crohn's. So, and sometimes we can see abscess formation and fistula formation to the abdominal wall leading to cutaneous fistula. So to understand features of Crohn's inflammatory bowel disease, these are the take-home points we must remember. There should be circumferential wall thickening. There must be mural hyperemia of variable Limburg score in acute inflammation, transmural spread of inflammation, peri-enteric fat reaction, peri-enteric abscess or fistula formation in complicated patients, skip lesions, that is areas of spared bowel in between. In chronic cases, there is stricture formation with proximal dilatation, with off and on history of subacute intestinal obstruction. Means there is partial obstruction in these patients. Now coming to another important entity of inflammatory bowel disease is ulcerative colitis. Let us understand by a couple of examples. This is male, 27 years, chronic bloody diarrhea, colonoscopy proved and biopsy proved case of ulcerative colitis. This is already biopsy proved case, came to me. So I'm scanning descending colon and sigmoid colon from splenic flexor down to the left iliac fossa in transverse plane. Let us see. The bowel wall is, the layer pattern is maintained, not very much thick. This is sigmoid, this is sigmoid colon. So this is transverse, descending colon in transverse view. This is sigmoid, and this is upper part of the sigmoid colon. Now on color Doppler, we can see marked hyperemia. So here we see the bowel wall thickening is within normal limit, but there is hyperemia, and patient is symptomatic, and it is biopsy and colonoscopically proved case of ulcerative colitis. But what other important feature we can see is the ascending colon of the same patient shows normal hostel pattern. This is empty colon, normal hostel pattern, whereas the descending colon shows, blunted hostra with the distance between two hostra is increased. The distance is increased. Here the compactly arranged, normally appearing hostra. Whereas in descending or the affected part of the colon or sigmoid, we see blunted and distance between hostra is increased and there is hyperemia. So thickness is not the criteria in this patient. The blunting and paucity of the hostel pattern is the criteria and the vascularity. So this is how we see ulcerative colitis findings. This is what we have seen in that case, and this is another case, descending loop, proved case of ulcerative colitis. But here the picture is different. There is slight wall thickening present, but not very much, as it is increased as compared to this case. But hostel pattern is totally lost. So it is a pipe-like descending colon. So there is complete loss of hostel pattern in this case, whereas the hostel pattern is blunted and reduced in number in this case. So both are proved cases of ulcerative colitis. So coming to salient features of ulcerative colitis, it is involving more common on left side colon, rectosigmoid wall thickening. It is a milder form of disease restricted to mucosa. So there is no pus thickening. Mural thickening usually proportional, but contrary to Crohn's disease with preserved stratification in initial stage. The bowel gives target-like appearance in transverse plane. There can be increased mural vascularity, paucity, blunting of hostra in initial stage, and there can be loss of hostrations in late stages, leading to straight, late pipe-like appearance of the colon. We may appreciate mural hyperemia, particularly mucosal and submucosal hyperemia. Less transmural involvement, so less pericolonic inflammation. So pericolonic findings are less common. Pericolonic, mesocolonic thickening is less common in ulcerative colitis, but it is very common in regional uveitis or Crohn's disease. So these are salient points. Now comparison, Crohn's disease can involve any part of GIT, but mostly ileocecal area is involved. All layers are involved. Peri-enteric fat reaction is an important finding. Skip lesions are present. Skip areas are present. It can complicate into abscess, fistula, and sometimes we may see extraintestinal symptoms in these patients because of involvement of the other systems. Whereas in ulcerative colitis, it is mostly affecting left side of colon and rectum. The disease mostly affects mucosal layer, causing its inflammation. Pericolonic fat reaction is less, no skip lesions, there is continuity in involvement. It can complicate with bleeding per rectum or toxic megacolon. Extraintestinal symptoms can be present in these patients also. So this is how we can compare between both the conditions. Now coming to another entity, which is rather more common, infectious ileocolitis or infective etiology leading to uveitis and colitis. So here the etiology is the infection can be bacterial or viral, and sometimes we may see parasitic infestations. So there is diffuse long or short segmental wall thickening. Hyperemia on color Doppler is again important. wall layer pattern is preserved in most of the conditions, most of the situations. Pericolic fluid may be present, and large mesenteric lymph nodes are again a common finding. And I must say, you can see sometime in these patients toxic hepatitis and hepatomegaly. There can be involvement of splenomegaly. There can be involvement of the gallbladder sometime, not always, but in some cases. So these are salient features: infection, viral bacterial infection, wall thickenings, diffuse circumferential, hyperemia is present, layer pattern is preserved, pericolonic fluid may be present but no fat reaction. Mesenteric lymphadenitis is associated particularly in the infections and TB. So let us take this example of female 9-year presenting with acute abdomen, fever, diarrhea, vomiting. These are the lymph nodes of the mesentery. You can, this is the ileum which is swollen. This is the terminal ileum in the long plane. So here there you can see hypoechoic thickening of the submucosa. Normally it is hyperechoic. Now in this case it is hypoechoic. Again see, these are lymph nodes, hypoechoic lymph nodes. So this is muscularis mucosa and submucosa is hypoechoic because of hypertrophy of the Peyer's patches. And sometimes we can see mural layer, as we can see in this case. So there is a deep ulceration which lead to mural layer, and this is how the infection begins to involve the submucosa and reach. So this is terminal ileum which is thickened, but blood signature is preserved. Hypoechoic thickening of the Peyer's patches, hyperemia on color Doppler, and associated mesenteric lymphadenopathy with marked hyperemia. These are salient features. No perienteric fat reaction is seen because there is no transmural spread of infection. Another male 22 years. That was child. Here it is male 22 years. Pain, right iliac fossa, diarrhea and fever, acute onset. We can see slight thickening of cecum. This is IC junction. This is terminal ileum, which is edematous. This is appendix. And some nodes are also seen. These are the nodes. These are the nodes. But no perienteric fat reaction or inflammation of the mesentery is seen. Gut layer pattern is preserved. Hyperemia is present. Nodes are present. In acute onset with history of diarrhea and fever, it is suggestive of infective ileocolitis involving ileum as well as cecum and adjacent part of the semicon. Young boy, 17 years, pain abdomen, bloody diarrhea. Here there is history of blood stained diarrhea. This is sigmoid colon, which is thick and edematous. This is bladder and this is the pelvic area. So there is significant thickening of the mucosa and submucosa. Muscle layer is all right, serosa is all right, no significant fat reaction seen. Acute onset. So you can see, diffuse thickening of the colon, prominent hostile pattern. Mucosa and submucosa is thick. There is marked thickening with hyperemia. In acute onset, it is infective rectosigmoid colitis, a case of rectosigmoid involvement. Again, a boy of 7 years of age, pain abdomen, history of fever, bloody diarrhea. In pediatric patients, particularly when there is history of blood-stained diarrhea, it is important. The physician wants to rule out intussusception, which is very important, condition which needs surgical treatment, and which is a serious, it can complicate into gut ischemia. So in every child with blood-stained diarrhea or bloody diarrhea or bleeding per rectum, it is important to rule out surgical cause, like intussusception. So in this patient, the child was sent for to rule out intussusception. Let us see. There is diffuse involvement of the colonic loops. So there is diffuse colonic loop. No intussusception was seen in that patient. So again, this is male 5 years of age, young child, pain abdomen, pyrexia, vomiting, and bleeding per rectum. Again, patient came to rule out intussusception, but child was having multiple rashes on the body surface, particularly of extremities. What we can see here, multiple reddish spots suggestive of rashes. And all the jejunal bowel loops are thickened, and shows marked hyperemia on color dot and power engines. The mesentery is reactionary. So in view of, this condition is known as jejunal vasculitis or jejunitis in case of Henoch-Schönlein purpura, which is a IgA-mediated vasculitis leading to involvement particularly of the duodenum as well as jejunum more than the ileum. There is diffuse thickening, hyperemia, and sometimes we can see echogenic areas within the mucosa suggestive of hemorrhages. And because of massive hemorrhages, there is intussusception formation and bleeding per rectum, leading to bleeding per rectum. But fortunately, this child was not having intussusception. Only there were involvement of the jejunum leading to jejunitis or jejunal vasculitis. The complications in jejunal vasculitis are severe massive GI bleed or formation of the intussusception and rarely perforation. Again, this is another pediatric case with presenting with fever, pain, abdomen, bleeding per rectum, and rashes over body. In this case, there was history of vomiting, excessive vomiting in this patient. This is upper abdominal scan showing liver, gallbladder. This is duodenum. This is particularly duodenal, first part and second part. This is stomach. This is duodenum. Duodenum is thickened. You can see thick duodenum. Entire duodenum is thick. You can see your massive duodenal thickening. There is nodes also present in periduodenal area. And rest of the bowel loops were all right. So this is how we see diffusely edematous and thick duodenum with periduodenal, edema. This is edema. And hyperemia on color Doppler. And we can see some fat reaction, periduodenal fat and small lymph nodes. So it is a case of acute duodenitis in a case of anoxia and lymphadenema. So always focus on every part of the intestine. In this case, only duodenum was involved. Rest of the bowel loop, small bowel was spared. Now coming to 8-year-old boy with pain, abdominal vomiting, but there was history of malignancy. Means there is some passage of leakage of blood in the GI tract. This is upper abdominal scan, high resolution scan of the stomach. We can see in the static images that the wall is slightly thickened, but the rugal pattern is preserved, layer pattern is preserved. On color Doppler, we can appreciate hyperemia. In the perigastric region, we can see some fat reaction and small rounded hypoechoic lymph nodes. So acute history of upper abdominal pain, vomiting, and meligna. And rest of the abdomen was normal. Normally, we can see stomach like this. In the pediatric patient, when there is collapsed stomach, is seen like this. Here, it is thickened with mucosal diffuse edema and thickening of the wall and mucosa, hyperemia, perigastric fat reaction, and small knots. So it is a case of acute gastritis. And on endoscopy, pediatric endoscopy was done in pediatric by the pediatric gastroenterologist, and it was reported to be a case of erosive gastritis. Another example. Male 35 years of age, but there is history of chronic upper abdominal pain, anemia because of occult bleeding per valve. There is chronic blood loss through GI tract leading to anemia, weakness, and upper abdominal pain. The routine probe, I'm examining with routine convex probe. There is thickening of the stomach wall, 11 mm in the transverse plane as well as in the longitudinal plane. I have examined the same stomach on high resolution scan for better neural details. There is thickening of the submucosa predominantly and mucosa, submucosa. CT was performed in this patient. There is thickening of the intropyloric region. Endoscopy confirmed diffuse erosive gastropathy. Biopsy was taken and biopsy confirmed chronic erosive gastropathy. So this is a case of diffuse erosive gastropathy. We can see layer pattern is maintained, but there is thickening. Now another important case, male 45 years with chronic liver disease and portal hypertension, presented with meligna. So we can expect in portal hypertension, we expect, esophageal varices because of the portal hypertension, leading to hematemesis and sometimes associated meligna. So this is epigastric scan. How we identify esophageal varices? I'm just trying to show this. So this is left lobe of liver. This is gastrohepatic ligament, in which the left coronary vein, the left gastric vein runs. We can see it is dilated and tortuous, which reaches to the gastroesophageal junction and forming collaterals leading to mural and mucosal submucosal varices in the esophagus, which are only seen after endoscopy or endoscopic ultrasound. So this is dilated left gastric or coronary vein in the gastrohepatic ligament, which is an indirect sign of esophageal varices. Now in the same case, the stomach was also thickened. And on high resolution scanning, we can see some cystic areas in the wall like this. And on put color with low flow setting, we can see these are vascular channels. So we can see even the gastric varices on ultrasound. So this patient presented with meligna. So basically, meligna can be because of esophageal varices or bleeding from the gastric varices. So these are gastric varices. So this is a case of chronic liver disease with portal hypertension presenting with portal gastropathy and gastric varices. These are gastric varices. And dilated coronary vein suggestive of is an indirect sign of esophageal varices. Now coming to male, 14 years male, chronic upper abdominal pain with anemia episodes from meligna. This is duodenum. This is left liver and this is duodenum. See the duodenum. Again see. This is thickened. First part of the duodenum is thickened, hypoechoic thickening. There is a erosion in the mucosa, which is ulcer crater. Typical ulcer crater with air within it, HH sign, hyperechoic air in the ulcer crater and hypoechoic thickening of the overlying muscle layer. And fairly touching the muscle layer. 14-year-old boy presenting with anemia, chronic blood loss because of this ulcer. And this ulcer appears to be chronic ulcer. This is not acute ulcer. This appears to be chronic ulcer. The wall is massively thick. Patient went for pediatric endoscopy, and this endoscope shows a large ulcer resembling with our ultrasound image. So this is how we can even pick up duodenal ulcer. Male 32 years presenting with upper abdominal pain and melena and weakness. So this is routine convex scan. This is convex scan, convex probe, routine examination. This is liver. This is duodenal area, first part of the duodenum. So on constant observation, I could see that there is a persistent defect in the wall. So I suspected some ulcer wall. But this probe is not better for evaluation, So I went for linear probe. And with linear probe, I can see this is stomach, this is duodenum, which is thickened. There is a large ulcer, which is reaching the serosa. It is touching the serosa. And there is marked periduodenal fat reaction, sealing it. It is sealing it. So there is impending perforation, or there is slight perforation. It has sealed. It has been sealed. This is ulcer. This is ulcer. So this is ulcer. And this is fat reaction. So it is impending perforation. So this is the comparison between the routine convex probe and high resolution probe. Patient went for endoscopy. This was ulcer. This was a fat, periduodenal fat, which has sealed the impending perforation because the inflammation has reached beyond. There was a large ulcer. Male 32 years. So this is how we have seen, pediatric patient with a duodenal ulcer, with a young adult with duodenal ulcer. And similarly, we can see such type of ulcer in gastric antrum also, with the same ultrasound morphology. So in duodenal ulcer, there is usually upper abdominal pain, there is histiomelena because of the chronic bleed, HH sign, hyperechoic ulcer crater with hypoechoic wall thickening. Periduodenal fat reaction and nodes can be seen as a result of inflammation spread. In chronic cases of duodenal ulcer, there is cicatrization, there is scarring, there is fibrosis, leading to narrowing of the gastric outlet and proximal duodenal area leading to gastric outlet obstruction. So I've seen a couple of cases where there is chronic cicatrization and narrowing in the duodenal first part and the gastric outlet area. Female 14-year premature neonate with vomiting, abdominal distension, bleeding per rectum, lethargy, refusal to feed. High resolution scan shows few tiny bright foci within the wall of the small bowel. These are abnormal. Suggest show some air foci. Pneumointestinalis. These are abnormal. Some bowel loops are showing little bit more air foci, visible, mural air. And very dirty bowel loops, dirty looking bowel loops. And when this bowel gas or these bowel bubbles can reach to portal circulation through portal vein, these air bubbles reach to the liver, leading to seen as a bright foci within the portal territories and parenchymal, multiple parenchymal bright foci. So pneumointestinalis with pneumohepatis because of the portal in the portal radicals, suggestive of necrotizing enterocolitis. Now, another findings are edematous bowel loops. There can be presence of ascites. There can be perforation. There can be obstruction, depending upon the complications. So NEC is serious GI infection, inflammation leading to bowel necrosis. Risk factors are prematurity, low birth weight, formula feed. At ultrasound, what we can see edematous bowel loops with pneumointestinalis, portal venous gas, and ascites. 43-year male, a case of renal failure with pain abdomen. This is right iliac fossa high resolution scan. This is cecum, edematous. This is abnormal. This is abnormal. This is ileal loop. So cecum is showing some wall thickening with preserved signature, but there are two hypoechoic rounded cystic areas within wall of cecum, full of internal echoes, low level echoes. Some fat reaction. This is because of typhlitis with cecal wall abscesses formation. Because a patient with renal failure is always compromised patient, so chances of secondary infections are more common in cecal area and ascending colon, leading to bacterial infection leading to abscess formation. So we can see abscesses within wall of cecal. Another case, male 22 years, chronic pain, anorexia, wet loss, anemia, occult bleeding per rectum. This is cecum showing slight thickening. IC junction is again slightly thick. Terminal ileum showing slight wall thickening. Cecum thick, IC junction thick, terminal ileum thick. This side it is okay. So there is involvement of cecum, IC junction, and terminal ileum eccentrically. not circumferential. This is the transverse scan. Half of the anterior wall of the cecum is involved with hyperemia, with multiple nodes, in the mesentery. Some are matted, showing necrosis and calcifications. So now these are the findings, what we suspect. There is history, chronic pain, abdomen, anorexia, weight loss, anemia, upper per rectum. So this is typical ileocecal tuberculosis with mesenteric lymphadenitis. So it is ICTB. Another case of ileocecal tuberculosis presenting with small subacute obstruction, means recurrent fullness and vomiting with incomplete obstruction because of this long stricture involving the terminal ileum with cecum and proximal dilatation. This is the strictured area. So there is ileocecal thickening with cicatrization. You can see, hypoechoic loss of blood signature, some fibrotic areas. It is irregularly thickened with proximal thickness. This is again a case of ileocecal tuberculosis presenting with SAIU. So ICTB is ileocecal. The area is the common site for involvement. There is hypoechoic thickening. Maybe circumferential, may not be circumferential. Enlarged matted necrotic mesenteric lymph nodes. There can be ascites or peritoneal thickening when the peritoneum is in. In abdominal tuberculosis, there are various types of tuberculosis. It is involving intestine, that is ileocecal tuberculosis. When it extends and crosses serosa and then involves peritoneal cavity, then it causes tubercular peritonitis, leading to multiple peritoneal nodules, omental caking, omental thickening, omental nodules, mesenteric nodules, serosal nodules, interloop thickening, matting, so on and so forth, and associated ascites with internally caused debris or septas. But this is typical intestinal tuberculosis. Now, another case, male 28 years, pain abdomen, low-grade fever, wet loss. This case will show spectrum of Cox symptom. Like we can see periportal and peripancreatic lymphadenopathy with some necrotic changes. Portal nodes, peripancreatic node. This is a common site again. Ascites, peritonitis leading to visceral peritoneal thickening. Internally caused septic, thin septies, diffuse omental thickening. Omentum is always seen just deep to the abdominal wall. And it is only seen when there is thickening and then ascites is present. Then it is better seen. And bowel loops are little bit matted. They are matted. They are stick to each other with sluggish movements. Right pleural cavity shows pleural effusion with some septas, a slight pleural thickening. Left pleural cavity also shows septate effusion, pleural thickening. The same patient. So by extending our examination to the pleural cavity, we are now sure enough. And this patient showed pulmonary tuberculosis also. So this is a tubercular spectrum, Cox abdominal spectrum. Intra-abdominal, portal, peripancreatic lymphadenopathy, mesenteric lymphadenopathy, peritonitis, ascites, septi, omentitis, matching of the bowel loops, bilateral pleural cavity, effusion and thickening. Pulmonary Cox as well as pleural thickening. So this is extended examination, and now we are sure of our diagnosis. And the same patient showing matted loops. This is how matted loop, see, it's like they stick together. It shows very. Just excuse me for 1 minute. Now another case. Male 31 years, chronic pain abdomen, anorexia, weight loss, low-grade pyrexia. Low-grade pyrexia is very important. Night sweats and fever in the evening, rise of fever and night fever, night perspiration, weakness. When we use high-resolution probe, we see this omental thickening, heterogeneous omental thickening in this patient. If you don't apply, you will miss this. Ascites, low-level internally caused, nodes, mesenteric nodes. But importantly, the spleen is showing multiple hypoechoic foci of variable size. The same patient. So these are the small lesions are granulomas. These are microabscesses. So basically, this is the case of Cox abdomen involving Cox peritonitis and ascites, lymphadenitis, and visceral involvement, spleen showing granulomas and microabscesses. And this is how we complete our diagnosis. Now coming to another entity which is very important entity, that is appendicitis. So appendicitis happens when there is luminal obstruction. It may be because of fecolith, appendicolith, or hyperplasia of the lymphoid follicles leading to obstruction or any infection that can obstruct the lumen, and there is appendicitis. So clinically, initially there is epigastric or periumbilical pain, later shift to right iliac fossa with rebound tenderness in the RIF, associated leukocytosis and increased CRP. High resolution probe is very important in evaluation of the appendix. We use gentle graded compression in these patients because there is marked tenderness. So gentle graded compression technique is applied. Abnormal appendix is usually showing diameter more than 6 millimeter, but I should say diameter is not sole criteria. When it is perforated, the diameter will be reduced. So, but in unperforated, non-perforated or uncomplicated appendicitis, the diameter is usually more than 6 millimeter. Outer to outer, it is non-compressible, tubulo-target tender lesion, tubular lesion with gut signature, target-like lesion in gut signature with gut signature. Fecalith is appreciable. Wall thickening is seen. Hyperemia is seen. Adjacent inflammatory changes in the periappendiceal area or mesoappendix is thick when there is spread of infection beyond serum. Now, secondary signs of appendicitis. Appendicitis are echogenic submucosa. This is echogenic submucosa. Target-like appearance, presence of appendicolith or fecolith, pericecal fat reaction, pericecal fluid, adjacent cecal wall edema and adjacent ileal edema can be seen because of local, inflammation. And we may see mesenteric lymph nodes. So these are secondary signs, and these are the direct signs: tubulo-target tender lesion, diameter more than 6 millimeter, mural thickening, mural hyperemia, presence of fecolith, or some internal echoes or debris within the lumen. Complicated appendicitis, when there is perforation, there is spread of infection beyond lumen. So there is local peritonitis, there is abscess, marked omental reaction, lump formation, there can be adhesion, there can be obstruction, there can be peritonitis. 15-year male with acute pain RIF. Cecum attachment, appendix, thick wall, fat reaction, well delineated, all layers of wall of the appendix, all layers are well seen. Mucosa, submucosa, musculus propria, and the fecolith is seen. Small fecolith is seen. Diameter is more than 6 millimeter, 10 millimeter. Anteroposterior, it is non-compressible. It is hyperemic. The entire wall is showing significant grade 4 hyperemia on color Doppler. So this is uncomplicated. There is no fluid, there is no abscess formation, no any other complication present. So it is acute appendicitis, uncomplicated. You have to examine and see entire, appendix. This is the case with pain and tenderness RIF. But when I saw the attachment of the to cecum is normal up to normal. When you see this much and complete your study, you will misdiagnose. You will, miss the diagnosis. Here the tip is swollen with some fluid collection wall thickening. This is tip is swollen. Tip is swollen. Tip is swollen and hyperemic. Only this part is inflamed. So this can perforate. I have seen cases the mid part is involved. This is normal. This is normal. I have seen cases where this part is involved, inflamed. This is normal. This is normal. So segmental involvement can be seen. However, it is very uncommon. But in this case, only tip appendicitis is there. Yes. Now, appendicitis clues. Presence of small, rounded hypoechoic nodes adjacent to ileum are again suggest you some infection and inflammation in RIF. This is appendicitis. Sometimes this comes out in the background of echogenic perinodal reaction. So small nodes, rounded nodes are abnormal, always abnormal. 9 into 6 millimeter size nodes. Cross section diameter is 8. There is mild ileal reaction and this appendicitis. Curved appendix is there. So other clues are mild local fluid when we see pericecal fluid, focal typhlitis, focal ileitis, ileus, dilated bowel loop in the right lower abdomen, focal federation. These are indirect signs of appendicitis. For example, this case, obese patient with pain and tenderness RIF. I could not see anything on compression. I could see just a small hypoechoic area with fat reaction. That's it. Everything is obscure. So hefty patient. On high resolution image, I can't see anything except a small fat reaction. Even this area is not visible. So this fat reaction, trace amount of fluid or hypoechoic area suggests some fluid. On graded compression, I can appreciate some layer, 2 layers. I can just. So it is appendicitis. So these are indirect signs sometimes. The patient went for CT scan and it was confirmed. So sometimes you don't find in obese patient, you see just fat reaction and small fluid, and only part of the appendix is seen. Another complicated appendicitis with perforation. So appendix is collapsed, diameter is not much, but there is fat reaction, some wall continuity is lost over here, focal loss. In transverse plane, we can see there is defect in the wall with perifocal fluid, this fluid, and some fat reaction. there is discontinuity of the wall. On color Doppler, there is discontinuity. And this is showing hyperemia. This is showing hyperemia. A very tiny perforation with focal. So with high resolution probe, you can sometimes see, small perforation. Another complicated appendicitis case, male 14 years with pain RIF, marked tenderness. And clinically there was a lumpish formation. This is right iliac fossa scan, marked fat reaction, omental mesenteric thickening, mesoappendix thickening. This is appendix, this is appendix, this is appendix, very long curved appendix, fecal debris, and a large fecal length is present at base of appendix. Large. See, this is fecal length, and the wall is lost its blood signature. The hyperechoic submucosa is distorted. Some debris are present. It is surrounded by fat reaction, which is trying to limit the infection. So this is fecal length, appendix, no vascularity of the wall. On color Doppler low flow setting, you don't see. So hypoechoic wall, loss of echogenicity of the submucosa, interrupted submucosa, marked periappendiceal fat reaction, no internal vascularity suggest gangrenous appendicitis. It is markedly gangrenous. So it is a complicated appendicitis leading to severe periappendiceal inflammation, infection, and lump formation. Another case of complicated appendicitis. Here you can see the cecum in the transverse plane, and there is marked abscess around in its posterior to it, and a part of appendix is seen. Rest of the appendix is ruptured. Only part is seen. And it is retrocecal in location, seen posterior to the cecum. So it is perforated retrocecal appendicitis with abscess. Now complicated appendicitis always perforates. So there is marked fat reaction, there is perforation, abscess formation, and sometimes we can see extraluminal layer again, which is indicative of local pneumoperitonitis, pneumoperitoneum. It suggests local perforation or the infection by the gas forming bacteria. The fluid contains internal echoes, debris, and some air, and the appendix is surrounded by fat reaction. Appendix diameter is very diameter is reduced because it is perforated. Male 33, pain, fever, diarrhea. There is ascending colon, cecum is very much thick, some mucosal thickening, some fat reaction. Appendix is also prominent, but wall is not thick. But appendix is showing diameter. So here, basic component of pathology is nephritis, but we can mention dilated appendix, which may be secondary to nephritis. So nephritis is secondary appendicitis. Appendicitis can be due to ileocolitis sometimes. Male 26 years, pain and tenderness, right iliac fossa, appendix, no color flow signals, interrupted submucosa, wall blood signature lost, gangrenous. The same patient is showing multiple liver abscesses. So multiple liver abscesses are pyogenic in nature because of the appendicitis, gangrenous appendicitis, formation of multiple pyogenic abscesses in the liver. So gangrenous appendicitis with pyogenic liver abscesses. Sometimes we don't see appendix. We are thoroughly examining, or we have thoroughly examined the patient, but we didn't see appendix. So in case of missing appendix, particularly in female patient, we can try PVS examination to see pelvic location. As in this case, there was acute pelvic pain with tenderness right iliac fossa. This is transvaginal scan. This is ovary, right ovary. See, there is fat reaction. There is marked fat reaction. There is lesion. This is the lesion. Fat reaction. This is bowel loop. This is lesion. So this is appendix. This is appendix. Marked fat reaction. Sitting adjacent to right ovary in the right adnexal location. So TVS again helps in evaluation of pelvic position appendicitis. Now another case, missing appendix. When we don't see appendix in right iliac fossa. Another case, uterus, target lesion, tubular lesion, pelvic appendicitis. Another case. Another case, liver, right kidney, Morrison space, Morrison pouch. Appendix is sitting, the tip of the appendix is sitting at Morrison pouch. Very old image. So it is high place of hepatic appendix. This is pelvic appendix. Again, a pediatric patient with acute abdomen, fever, missing appendix. There was a large abscess in the right flank. This is liver, this is right kidney. In the transverse plane, the abscess is extending from hepatorenal space to the right ileum. right iliac fossa. There was large, massive abscess with internal echo air foci within it. The same patient. In the right iliac fossa, I could see a fecalith over here. So fecalith is a indirect sign of perforated appendicitis. And only stump of appendix is seen at cecum. This is stump. This is discharged, or this is free lying, free floating fecalith, and there is large abscess in the pericecal area, right lumbar region, extending from subhepatic location to RIF. And you don't see appendix, but only stump is seen. This is stump of appendix. Another example, missing appendix. This is pediatric patient. Multiple metted bowel loops, thick walled bowel loop, internal loop thickening, fluid, septa. There is picture of peritonitis. But appendix was not at all seen. Not at all seen. There is mild hyperemia, peritonitis, some fluid, septa, thickening. But on thorough examination in right iliac fossa, I could see fecalith, free lying fecalith. So fecalith is again a indicator of ruptured appendix. So this was a case of ruptured appendicitis with peritonitis with free lying fecalith. So these are, various examples of missing appendix. What we should think in that situation. Now coming to another entity, that is mesenteric lymphadenitis as a infective pathology. Infection may be bacterial, viral, parasitic, tubercular. Adenitis can be seen in inflammatory bowel disease, autoimmune disorders, malignancies, lymphoma, and some miscellaneous conditions. Diagnostic criteria includes more than 3 hypoechoic round to oval nodes, size, cross-section diameter more than 8 mm or 8 to 10 mm cross-section. Shape is very important. Rounded, small round node is abnormal. So when the node is rounded, it is hyperemic, it is abnormal. Ecotexture is very important. When it shows heterogenic necrotic areas, calcification, it is tubercular. If it is hyperemic, it can be reactive or inflammatory. Necrosis, matting, sandwich sign. And most of the time, mesenteric adenitis is associated with bowel disease, either ileocolitis or appendicitis. When it is not associated with appendicitis or ileocolitis, then it is isolated mesenteric adenitis, which is seen in after diarrhea and viral infections. But diagnostic criteria includes more nodes, more than 3, short axis diameter, more than 8 or 8 to 10. Sometimes isolated entity can be seen, not associated with bowel disease. But to label isolated mesenteric adenitis, appendix should be normal. You must see appendix when it is normal, then you mention mesenteric adenitis. This is how we see multiple nodes, hypoechoic. The vascular pattern is typical, hilar vessel with ramifications and typical arborization. This is normal hyperemic pattern, normal pattern. When nodes are matted, heterogenic in ecotexture, necrotic changes, calcifications present. Necrotic abscesses, nodal abscesses. These are commonly seen in tuberculosis. Now, 6-year female child with pain abdomen with bleeding per rectum. On scanning, everything was normal. I can see a very small gut lesion outpouching from the intestine, small bowel, that is ileum, with typical gut signature, slight wall thickening, eccentric wall thickening, and cystic area. And the wall is showing gut signature. Very small lesion in the right iliac fossa scan on high resolution ultrasound. And this lesion shows vascularity increased within its wall, associated few mesenteric lymph nodes. And appendix was normal in this patient. I'm not showing over here, but appendix was normal, not inflamed. So this was a lesion attached to ileum with some nodes and inflammatory changes. So it was Meckel's diverticulitis. It was inflamed Meckel's diverticula, and as we know, Meckel's diverticula harbors gastric or pancreatic tissue or gastric tissue which ulcerate and bleeds, causing bleeding per rectum. Most of the time, these childs present with bleeding per rectum, painless bleeding per rectum. But in this case, it was slightly inflamed, so there was a pain. The lesion was small cystic, attached to ileum in right lower quadrant, not resembling with appendix, associated nodes, inflammation. So it is a case of Meckel's diverticulitis. So Meckel's diverticulum is a very common developmental anomaly seen in 2 to 3% of the population. Meckel's diverticulum is as a result of non-obliteration of the vital intestinal tract, leading to diverticular formation. It is seen on anti-mesenteric border, opposite the mesenteric attachment. Incomplete obliteration of the amphiromesenteric duct. Usually there is rule of 2 and it's seen in 2% of the population. It is 2 feet away from the IC junction. It is symptomatic within 2 years of age, and so on and so forth. Often contain ectopic gastric and pancreatic mucosa responsible for ulceration and bleed, GI bleed, hematochezia. It can complicate. Most of the time it complicates after inflammation and after perforation. It can ulcerate and cause severe hemorrhage. presenting with GI bleed or metastasia. It can cause obstruction due to inversion and formation of the intussusception, and due to fibrous vitelline cord attached to umbilicus leading to axial rotation and obstruction, or due to presence of mesodiverticular band leading to obstruction due to adhesion. So it can cause inflammation, ulceration, hemorrhage. It can cause obstruction of the small bowel due to inversion and intussusception formation, and due to obstruction due to vitelline cord or mesodiverticular band. If it is inflamed, clinically resembles with appendicitis. Hemorrhage and hematochezia is most frequent complication. Now, ultrasound features of Meckel's diverticulum. It is seen as a tubular, small tubular lesion, small cul-de-sac like teardrop-like lesion, or small cystic gut lesion with typical gut signature, usually in right lower abdomen or infraumbilical, right in perumbilical location. And most of the time, it's attached to umbilicus in some cases. So when it is the lesion attached to umbilicus, it is surely suggestive of Meckel's with band. So this is a very important criteria in diagnosis. If suppose you see a gut lesion, not appendix, and one of its end is attached to retroumbilical area, you can suspect, Meckel's with vitelline cord. When inflamed, there is wall thickening, hyperemia on color Doppler, adjacent fat inflammation, focal interloop abscess formation when it ruptures. There can be pneumoperitoneum if it is perforated. And most of the time, the child usually presents with bowel obstruction due to persistent vitelline cord attached to umbilicus causing axial rotation and volvulus formation, or mesodiverticular band causing torsion, twist, or trap of the bowel loops seen as whirlpool-like lesion at zone of transition. Associated findings can be ascites and mesenteric lymphadenopathy. It should be differentiated from duplication cyst and appendix. Appendix is attached to cecum. It is very long tubular structure, typical signature, typical location, typical attachment. Duplication cyst is quite resembling with, Meckel's, but it is more rounded. It is also tubular, attached to ileum, so it is very difficult. But normally it is rounded and very large. Its lumen may communicate with, bowel, and muscle layer of this duplication cyst is continuation of the muscle layer of the native bowel. So these are certain salient points. Still, it is difficult to differentiate from duplication cyst. Now coming to another entity, that is diverticulitis. So it is common in elderly people, and low fiber diet, constipation, hereditary factor, altered bowel habits are the common symptoms. These are mural outpouching lesions. Because of defect in the muscularis propria, the mucosa comes out with fecal matter, get infected, get obstructed, perforate, form abscess, and inflammation. On colonoscopy, we can see small defects. These are common in sigmoid and descending colon. When inflamed, there is focal stasis of infection. Then there can be perforation, abscess, and fistula formations. On ultrasound, hypoechoic colonic wall thickening with hyperemia in the affected segment. There is always wall thickening present. There is mural echogenic outpouchings. Diverticulars are seen as mural outpouching lesions with dirty shadowing because of the fecal matter. If there is inflammation, there is marked fat reaction around. Pericolonic hyper or hypoechoic lesion with abscess, air foci, and echogenic inflamed fat reaction. So these are ultrasound features. Let us see. Male 65-year pain left iliac fossa with tenderness, history of fever. High resolution scan of the left iliac fossa. I am seeing the descending colon and sigmoid. This is edematous. Some mucosa are thick, hypoechoic muscle layer. There is diverticular. So it is diffusely thicker. Large diverticular with air. Hypoechoic. Some diverticulars are hypoechoic and some are echogenic. These are inflamed diverticulars, hypoechoic. This is a small fluid-filled cystic area, fluid-filled. Some air focus, fat reaction. When we put color, this particular segment will show hyperemia on color. Another female, 49 years with pain, left iliac fossa, pyrexia, leukocytosis. There was tenderness in the left iliac fossa. This is the transverse skin of the sigmoid colon. There is a ecodensity outside the lumen, and there is hypoechoic ill-defined area with marked fat reaction. So there was significant pericolonic inflammation, and this is small diverticula which is inflamed. This is the longitudinal plane. This is the diverticula which is inflamed. There is a fat reaction. On color Doppler, we can see hyperemia. So this is a single diverticula which is inflamed in this female 49 years. And in earlier case, there were multiple diverticulas. Some are inflamed and some were normal. So this is how we see a outpouching lesion, which can be hypoechoic or hyperechoic depending upon the contents. If fecal matter is present, it is echogenic. If the fluid is present, and because of inflammation, there is hypoechoic, then marked fat reaction around. So this is a diverticulum, and adjacent regional colon will show slight thickening and hyperemia. Slight thickening and hyperemia. And after treatment, the diverticula resolved, and the inflammation resolved, and the small diverticula with small fecal matter is seen after treatment. Now this young patient with chronic vein abdomen, I'm examining small bowel. I can see some intussusception-like area with some abnormal foci. See, this is abnormal, this is abnormal, this is abnormal, this is abnormal. And there is transient intussusception with some rounded target-like abnormal structures within, which is the structure is long, trump rake-like. Transient intussusception with a small dot-like area within it, which is on long scan, which is tortuous elongated structure within the bowel lumen. This is intestinal vasculitis. The patient was given same day, same night, patient was given deworming, and in the morning passed a large ascaris. I explained the mother of the child that you please see the stool in the morning. There is a large ascaris in it, and this is ascaris. So ascaris can be seen in the lumen. There can be single ascaris, there can be multiple ascaris, right? So this is single ascaris, and there is transient intussusception formations. Now male 65, pain, abdomen, pyrexia, loose motions. I'm examining liver. There is abscess coming down to kidney and right iliac fossa. Abscess coming down in the right iliac fossa, hypoechoic thickening of the wall of the ascending colon and cecum. This is stamina ileum. So whenever you see liver abscess in the acute stage or in the short duration, you always see right iliac fossa for typhlitis or ileocolitis, as we can see in this case. So there is a large single abscess, and in gangrenous appendicitis, so multiple abscess. There were pyroric abscess. This can be, single large abscess can be amoebic abscess. So this can be amoebic typhlitis, abscess, thickening of the cecum. Now see the difference of convex probe and high resolution probe. Diffusely thick, but there are cystic area within the wall of cecum. These are wall abscesses, cecal abscess is small, or what we call it as amoebomas. So yesterday I told that I will show you one case. So this was drained as Encobis hospus, and this was a typical case of amoebic colitis or amoebic typhlitis. And these are large, amoebic abscesses in the wall of the cecum and associated abscess in the liver. Single large abscess, amoebic typhlitis, cecal wall abscesses. This is convex probe resolution, this is high resolution probe. See the difference. So this is the importance and beauty of high resolution ultrasound, particularly in evaluation of the bowel. Now, this is the case of inflammatory rectal disease. The female of 30 years presented with bloody diarrhea. And on abdomen, there was nothing significant. Ileocecal area was normal, colon was normal. On transvaginal scan, I can see rectum, part of the rectum is diffusely thick and edematous with prominence of the submucosa and perirectal slight inflammatory fat reaction with hyperemia. So it is an inflammatory rectal disease or proctitis. Female 30 years, painful defecation with blood and pus mixed stool, histopyrexia. So according to the symptoms, we switch to the region of interest. So there is painful defecation means there is locoregional pathology, anorectal pathology. In a female patient, we have transvaginal approach with us. As we can see, this is transvaginal probe at outlet of the vagina. This is urethra, this is vagina, this is outlet at outlet. Posterior tilt, we can see anal canal, and in the anterior to anal canal, there is small hypoechoic, small abscess. This is small abscess, very small abscess, causing painful defecation. Now, when we make proper angle, so this is anal canal and this is abscess anterior to it. So perianal abscess. Now still with high resolution probe. These images are of transvaginal probe. Now coming to linear probe. So there is abscess, there is internal sphincter, lumen, external sphincter, and we can see anal opening, internal opening within the anal canal at 11 to 12 o'clock position. So this is perianal abscess with internal opening at anal canal. No external opening is present at present. Another case, there is internal opening, there is abscess at 3 o'clock position, crossing the external sphincter, internal sphincter. So transsphincteric abscess, ilioanal abscess. And there is a fistula tract in the perianal area at 2 o'clock position. So there is abscess, there is a fistula, there is internal opening, there is external opening. We have to mention the amount, the size of the abscess, the length of the fistula. its course, whether it is an intersphincteric, whether it is a transsphincteric, whether it is having internal opening only, whether it is having external opening also. And this is transvaginal application in a female patient with perineal pain and abscess. This is abscess and this is fistula. Now, this is all about, we have included various inflammatory pathologies, right from infection, inflammation, inflammatory, other causes of the bowel GI tract. Now we are coming to bowel masses. So bowel masses are because of either bowel wall thickening or luminal mass or mural mass or having a external mass. So benign bowel masses or benign bowel pathology, benign bowel wall thickening involved long segment. Just to recapitulate, there is concentric, regular thickening, preserved gut signature in acute phase, perienteric fat reaction like Crohn's, mural vascularity increase in acute phase, chronic IBD, altered stratification, wide zone of transition. There is always wide zone of transition in benign pathologies. Example, infection, inflammation. Now coming to malignant pathologies, malignant bowel wall thickening. There is localized, irregular, heterogenic hypoechoic wall thickening with loss of gut signature and layer pattern. This is commonly known as pseudokidney sign. Irregular contour of the bowel wall involved, loss of motility, loss of compressibility, and loss of configuration of the bowel in the affected segment. These are all salient features of malignant bowel pathology. Internal vascularity definitely seen, but less and bizarre pattern. Here the zone of transition is very narrow. There is abrupt pathology change. So narrow zone of transition, abrupt shouldering is there. Example, neoplastic. Let us see some case studies. So benign bowel masses are generally polypoid masses, which can be adenomatous polyp, hyperplastic polyp, hamartomatous polyps, or pseudopolyps. There can be lipomas or leiomyomas. Malignant masses of GI tract, most common are the adenocarcinomas, gastrointestinal stromal tumors, lymphomas, and sometimes metastatic bowel pathologies. Other bowel masses which are of different category are intussusception, bowel in bowel appearance mass, inflammatory masses or phlegmons or abscesses, or some intraluminal base or foreign bodies. So ultrasound, just we remember, we go through fast. Asymmetric bowel wall thickening, typically more than 10 millimeter, irregular, eccentric, or sometimes concentric, causing stricture formation. Loss of wall stratification, loss of mucosal, submucosal layer differentiation, narrow zone of transition, pseudokidney appearance, intraluminal or exophytic components, diminished peristalsis, diminished compressibility, absent peristalsis, loss of rigid segment, non-compressible, loss of bile gum configuration, localized bowel dilatation proximal to the mass. When there is significant stricture formation, there is partial or complete obstruction, there is proximal dilatation. So patient usually present with subacute obstruction in partial and complete obstruction after complete luminal obstruction. Color Doppler finding may show irregular chaotic vascularity. Regional lymphadenopathy may be seen, and large round hypoechoic nodes may show necrosis, suggest metastatic nodes. There is local invasion of the adjacent organ involvement, again suggests your malignant bowel pathology, because this disrupts the fat planes. Liver metastasis is most of the time it is a common association in colorectal malignancies. What we see in liver, we can see a hypoechoic or a target-like or a hyperechoic or a cystic liver lesions with hypoechoic halo around on abdominal scan. So these are salient features of bowel neoplasms, of malignant neoplasms. So these are common, appearances. Pseudokidney mass, hypoechoic periphery, central distorted echogenic lumen containing air and fecal matter. Narrow zone of transition, this is normal, this is abnormal. There is abrupt cutoff shouldering, irregular nodular thickening, non-compressible. There can be circumscribed thickening, loss of gut signature. Here the lumen is preserved. So it is a aneurysmal dilatation. Normally, there is stenosis of the lumen. Sometimes there can be intraluminal component, large intraluminal component. It's an intraluminal polypoidal mass. It is a malignant polypoidal mass. This is a short segmental hypoechoic thickening of the short segment concentric with irregularity, mucosal narrowing, typical apple core appearance in high resolution image. This is a colonic scan, transverse colonic scan, showing half of the wall is normal, half is eccentrically exophytic growth, luminal distortion, hypoechoic wall, loss of gut signature. Eccentric irregular mass. Aneurysmal dilatation with circumferential growth. Sometimes there is stricture formation and concentric growth is also seen, like benign pathologies in adenocarcinomas. And sometimes we can see focal thickening with ulcerated margins, ulcerated growth. As we can see in this case, this is a stomach scan. These are all colonic scans. So large ulcerated growth within the stomach. So these are various, patterns of bowel malignancies on ultrasound. Now case one by one. Benign bowel masses, let us take examples. Intussusception, you all know. It is common within the age of 6 months to 3 years of age. History of diarrhea, episodic cry. Clinical triad, very important. Abdominal pain, lump and red current jelly stool. These are the important signs. Most common is ileocolic intussusception. Ileocolic or colocolic, uncommon. Most common is ileocolic. At ultrasound, we see multi-layered bowel mass with bowel in bowel appearance, target-like lesion in transverse plane or donut sign in transverse, hair fork or pseudokidney sign in longitudinal plane, intraluminal mesentery or lymph node sign. Most of the cases will show intraluminal lymph node sign. And in 90% patients, there is no lead cause. In pediatric patient, only the Peyer's species hypertrophy lymph nodes are only present. In 10% of the cases, we may see lead point, which is bowel pathology, other which can lead to intussusception formation, like duplication cyst or any polyp-like lesions, any mass or malignancy. Doppler assessment is important to see the mural vascularity, whether it is normal, showing normal viability, vascularity, or absent vascularity. Complicated intussusceptions are basically showing massive wall thickening, poor vascularity, presence of ascites, changes of peritonitis, and small bowel obstruction. These are of fairly large size, more than 3 cm in length, more than 2 cm in short axis diameter. In uncomplicated patients, USG can be utilized for guided hydrostatic reduction. 90% of the cases, the etiology is common, like lymph node sign, bowel in bowel appearance. Most common site is ileocolic. It is seen in the right hypochondrium. The mass is seen in the right hypochondrium. And this is how the etiology happens. This is lymph nodes. There is thickening of the ileum, which becomes rigid. And because of aggressive peristalsis, this invaginates in the cecum at IC junction. And because of edema, it will not come back, and it is the lead point. So this Peyer's species hypertrophy and lymph nodes are the main cause seen in the pediatric patients. Bowel in bowel appearance, invaginated bowel loops, the intussusceptum, the mesentery, the intussuscipiens. In the longitudinal plane, the outer bowel, the inner invaginated bowel, mesentery nodes. Another case, female 1 year, abdominal colic, excessive cry, bleeding per rectum. This is liver, this is right hypochondrium. There is a multi-layered bowel mass with bowel in bowel appearance, lymph node sign. Most common location is subhepatic or right hypochondria. It is vascularity is normal. It is uncomplicated intussusception. It was reduced and fairly normal. This is for operative photograph of the same patient. Transient lead 2 we can see, but we must re-evaluate the patient. These are all normal sometime. But we have to mention that patient is showing transient intussusception formation because there can be underlying malabsorption or some small bowel pathologies. But this is not pathological. This is simultaneously reducing and forming, waxing and waning, no edema, short segment, ileoileum. Male 50 years with bleeding per rectum and obstruction, constipation. This is the left iliac fossa multi-layered bowel mass. In the longitudinal plane, we can see that there is a rounded mass at the lead point, as a lead point. This is the mass at the lead, which was a lead point, invaginated, and this is forming intussusception. So well-defined mass, echogenic, homogenically. So what we can suspect is this is a lead mass. Most likely it is a lipoma. So lipoma of the colon leading to intussusception. CT was done, there was a lipoma, and forming a colocolic intussusception. 5-year boy with pain, abdomen, vomiting, bleeding per rectum. This is the intussusception, large intussusception. Very old slide with a cystic lesion within it. I'm utilizing transvaginal probe for abdomen. On high resolution probe, we can see a gut layer appearance. This is a gut signature. So this is duplication cyst, which is a lead point in this patient, leading to intussusception, and duplication cyst is a lead point, which is a surgical case. Another companion case, there is intussusception, but there is a lead mass, lead point, hypoechoic mass in the small bowel. So it is an ileoileal intussusception, and there was some polyp in the small bowel leading to intussusception formations. So these are a couple of examples of intussusception with lead point. Now another case, 6-year female, recurrent painless hematochezia. Recurrent painless hematochezia, bleeding per rectum. Descending sigmoid colon, a small mass is sitting within its lumen. Very small mass. This is the mass. The mass is showing tremendous vascularity with a vascular stalk or pedicle. So this type of patients usually need preparation because until the bowel is clear, we cannot see. And I'm examining with a linear probe. This is a female, 6-year female. So I prepared abdomen 1 day prior to the examination. And then, because multiple reports, the attendant was carrying with normal reports. But still patient is having recurrent episodes of melena, hematochezia. Sorry. So this is the mass within the sigmoid colon, which is tremendously vascular. Pediatric colonoscopy was done, and there was a polypoidal lesion which was responsible for recurrent episodes of bleeding. It was a juvenile sigmoid colonic polyp. Another case, female 20 year recurrent abdominal pain showing another polypoidal lesion, interluminal polypoidal with pedicle and internal vascularity around it. But it is not causing intussusception formation, but this is an ileal polyp. So we have seen ileal polyps causing intussusception. This is incidental detection, and that was earlier child was having hematochezia. So polyps are abnormal growth in the lumen, benign. These are pre-malignant or malignant polyps, depending upon the age of the patient, common in colorectal region. They can be adenomatous, hyperplastic, hematomatous, inflammatory, and pseudopolyps, various types. Complications, most common is intussusception formation, obstruction, GI bleed. Liver, and this is stomach, intraluminal, intragastric, rounded, well-defined mass. Appearance is benign mass. Endoscopy was there was a smooth mucosa, no ulceration, nothing like that. The patient was evaluated, CT was done, biopsy was done, it was found to be gastric leiomyoma. So it is a leiomyomas or other GIST tumors are very common tumors. Usually these patients are asymptomatic, but ulceration may cause pain and bleeding. Present as endophytic, submucosal lesions may be pedunculated, but some arising from the serosa and may develop exophytic masses. But this is an endophytic mass. So well-defined lesion with surrounding mucosa, no any abnormal wall changes, smooth wall suggestive of benign nature. 4-year female with lump left iliac fossa hematochezia. Everything was normal. I see a well-defined hypoechoic bean-shaped mass of fairly large size, 7 by 4 centimeter in the left iliac fossa. On color Doppler, it is showing internal vascularity and some hilar vessels. This hilar area shows tremendous vascularity, the pedicle of vessels supplying the mass. So I utilize high resolution probe. I utilize TVS probe, and I can see this colon partly seen and partly effaced, and the mass is arising from colon, having a large exophytic component. Hilar appearance, same, and there was a large exophytic mass. So it is arising from colon, left colon. This is colon. So it was a large mass exophytic leiomyoma of sigmoid colon. Similar. See the beauty of ultrasound, the findings are similar. 6-year female, history of blunt trauma abdomen, complaint of pain, vomiting, bleeding per rectum. There was mild amount of free fluid was seen in abdominal cavity, and I can see hypoechoic mass along the jejunal bowel loops, which appears normal. Otherwise, no internal vascularity, exophytic mass along jejunal bowel loops. This is transverse plane, there was exophytic mass. So I suspected some hematoma, but most of the times hematomas are mesenteric side because of rupture of the mesenteric vessels. But this is exophytic, but non-vascular mass, no internal vascularity. Trace fluid. No CT was done. Patient was operated, and there was large jejunal wall hematoma. So these are a couple of examples of benign nature masses. Again, this is 15-year girl with chronic upper abdominal pain, recurrent vomiting, lump upper abdomen. She was mentally subnormal. So this is a stomach which is distended. This is liver. This is the pyloric era. There is a large echodense mass with distal obscuration, distal shadowing. Solid appearing mass in the transverse plane, echo density with distal shadowing. Nothing seen beyond it. It is taking the shape of the organ, that is the stomach. It was operated and large bezoar was found. So bezoars are seen. This is a trichobezoar, basically. So the mentally subnormal, child was having habit of recurrent, ingestion of the hairs, self hairs, and there is formation of the bezoar within the stomach, taking its shape. So bezoar seen as an echo dense mass within the bowel with distal obscuration. Cystic bowel masses. This is right iliac fossa scan showing a cystic area with internal echoes, some laminated appearance, elongated structure, typical location attached to cecum. See the difference in high resolution probe. High resolution probe will identify the internal lamellar appearance, onion peel appearance of the internal contents, which are not seen on routine. I've utilized transvaginal probe in the iliac fossa. Because with convex probe, it will be seen as a cystic area. That's it. On 3V probe, we can see some laminated appearance. With high resolution linear probe, we can see clear-cut onion peel appearance. So it was mucosal of appendix. When appendix is obstructed chronically, there is recurrent secretion of mucus, maybe because of adenocarcinoma at the neck or whatever may be the cause, leading to formation of mucosal. But it's a typical location, attachment with the cecum, elongated structure. These are hallmarks and cardinal features of mucosal of appendix. Male 4-year, acute abdominal colic, vomiting. There is this picture of obstruction. Right iliac fossa high resolution scan shows a gut lesion, large gut lesion, rounded cystic with some internal globules, internal bodies on 3D. But the lesion shows extraluminal air. There is some perforation and sealing over here. There's small amount of air is present adjacent and out to the lesion. Extraluminal air. This suggests perforation of the lesion. So there was a ileal duplication cyst with adjacent perforation and adhesion, leading to formation and this exhibition of the extraluminal layer or the focal pneumoperitoneum. Again, the reason is showing gut signature, large, multiple mucoid grain nodules, perforation, peritonitis, focal peritonitis. Now, malignant bowel mass is right from G junction. Male 73-year dysphagia, wet loss. This is the G junction in longitudinal plane. There is irregular thickening of the lower end of esophagus and cardia of stomach. This is the transverse plane, hypoechoic thickening, loss of gut signature, involvement of the stomach adjacent stomach. So this is neoplastic pathology at G junction. CT shows marked thickening of the lower esophagus and cardia of the stomach, showed red tail appearance. Endoscopy was done, biopsy was taken, turned out to be malignancy of the esophagus involving cardiac stomach. Another male 60-year pain abdomen weight loss melena. This is high resolution scan of the stomach. See the normal rugae. This is thickening with a large ulcerated lesion. This is large ulcerated lesion. This is loss of gut signature. This is normal rugal pattern. Normal fundic area in the antrum area, there is large mass with ulcerated. So there is ulcerated growth, loss of gut signature. There is a preserved gut signature in the rest of the stomach. Mural hyperemia. CT shows ulcerated growth. Endoscopy was done, biopsy taken, and biopsy showed diffuse signet ring CS stomach. So this is how we can differentiate the malignant ulcers. CS stomach. 42 male abdomen occult bleeding per rectum. Jejunum. This is jejunum, abrupt zone of transition. There is a regular thickening of the jejunum. Circumferential thickening. Lumen is maintained or rather dilated. Concentric thickening, loss of gut signature. Lumen is preserved or rather showing aneurysmal dilatation. Aneurysmal dilatation is a significant feature of, associated lymphadenopathy in the mesentery, a case of jejunal lymphoma. Another fat reaction, small segmental jejunal lymphoma. There is concentric thickening, lumen is preserved or rather aneurysmal dilatation with a large mesenteric rounded node. This is a pediatric patient, male 10 years. See a small segment with jejunum, focal jejunal mass, concentric mass with node. So lymphoma usually involves small bowel, more commonly affected, jejunum or ileum. Tumors are hypoechoic and show variety of growth patterns like circumferential wall thickening, nodular thickening, bulky tumor spread. Lumen is showing aneurysmal dilatation because gradual involvement of the mesenteric plexus. So there is the destruction of the nerve plexus, so the lumen remain dilated. So there is no obstruction in these patients. Mesenteric lymph nodes are present. When there is massive wall thickening, always suspect lymphoma, as in this case. Significant thickening, hyperemia, lumen is preserved, dilated. See the thickening, the mesentery is also thick. The tumor is extending within the mesentery, and there is thickening. Multiple extra intestinal nodules are present in the parietal peritoneum, along with the mesenteric nodules. So this is typical findings. These are the typical findings of lymphoma. Another female 50 years, pain abdomen, anemia, occult bleeding per rectum. Everything was normal except I could see very small bowel, small area of bowel with an exophytic mass involving the mesentery with slight fat stranding. This was the only finding in this patient. On very meticulous examination, this is gut because of this air. Wall is okay, but there is small lesion with exophytic component with fat stranding. Adjacent to aorta, this might be involving jejunum. Aorta, jejunum, and some exophytic mass. CT was done. There was exophytic mass involving jejunum. In the sagittal, the exophytic mass. In the coronal, there is exophytic mass involving jejunum with fat stranding. It was a jejunal gastrointestinal stomach tumor. So these tumors are basically having exophytic components. 1% involves stomach, small bowel, smooth muscle tumors. They are frequently very large size, may undergo ulceration, degeneration, necrosis, and hemorrhage. On ultrasound, we can see rounded mass, exophytic, dumbbell shape of variable ecotexture. Central cystic area shows hemorrhage and necrosis. This patient is having a rounded exophytic mass with mesenteric extension. 75 female, altered bowel habits, constipation, dull pain, history of recurrent bleeding per rectum, sigmoid. This is transvaginal probe for rectum. Rectal wall is irregularly thick. I'm utilizing transvaginal probe for abdomen. So this is sigmoid scenario. This is sigmoid colon. I'm examining by transvaginal probe. Putting the probe on abdomen for better resolution. So this is a short segmental hypoechoic mass, luminal narrowing, gut signature loss, shouldering, and loss of short, narrow zone of transition. Now see the high resolution images. Transverse, there is a target sign. So there is a normal abrupt mass, shouldering, normal. So there is a short segmental stricturing mass of the sigmoid colon, target like in transverse. See the beauty of high resolution scan showing this much of the segment is involved. This is the luminal narrowing. This is the mass, gut signature lost, shouldering, short segmental, neoplastic, adenocarcinoma of the colon causing stricture or the stenosing lesion. Typical apple core mass. See a sigmoid colon. Male 50-year, altered bowel habits with occult blood per rectum. Exophytic. This is a colonic scan with exophytic mass, eccentric mass, luminal narrowing distortion, adenocarcinoma of the transverse colon. Female 64, this case I showed yesterday, very small lesion in the rectum. I am examining the rectum by transvaginal route in this patient because there was history of painless rectal bleeding. For the first time, patient came to me and then I examined very small ulcer lesion, HS sign, hypoechoic wall thickening with hyperechoic ulcer flattening. With hyperemia, colonoscopy was done, there was ulcerated growth, biopsy taken, turned out to be C rectum. Again, case of C rectum, irregular growth extending beyond serosa, pararectal fascia, fat planes are distorted, perirectal invasion, nodes are present, again suggestive of malignant rectal growth. Female 60-year, recurrent, painless bleeding. Again, I'm examining rectum by transvaginal route. There is a polypoidal mass, smooth walled polypoidal mass present within the rectum with bizarre vascularity, multiple perirectal nodes, suggestive of malignant or neoplastic. This turned out to be C rectum with perirectal lymphadenopathy. Male 89, altered bowel habit, constipation. This is the left iliac fossa scan. High resolution scan. This is iliac artery. There is irregular wall thickening of the sigmoid colon with luminal narrowing and distortion. Narrow zone of transition. Transverse plane. The lumen is very much narrowed. Gut signature lost. Hard on elastogram. Definitely short segmental malignancy of the sigmoid. And at the same time, when you examine the patient, there were multiple liver metastatic lesions. So ultrasound is a modality of choice in initial pathology, in the initial examination of these altered bowel epithelial PR cases. And simultaneously, we can see the metastatic lesions. So adenocarcinomas are most common pathologies. Mostly involve stomach and colorectal regions. Irregular, infiltrative, polypoidal, fungating, ulcerated, stenosing lesions. Short segmental with narrow zone of transition and shouldering. And most of these adenocarcinoma lesions causing narrowing of the lumen and stricture, as opposed to the lymphoma, where there is aneurysmal dilatation. There is always loss of layer pattern, associated lymph nodes or liver metastasis are the associated findings. Sometimes bowel can be involved in metastatic pathologies. Malignant melanoma, carcinoma lung, breast, CA are the common findings in which we can see metastatic bowel lesions. Ascites, we can see ascites, omental, kicking, peritoneal nodules, eccentric hypoechoic gut, mural or serosal masses. Like in this case, there is a focal deposit in the serosa of the lesion, a bowel metastatic lesion, a follow-up case of CA vagina, showing a focal metastatic lesion. A follow-up case of CA ovary showing a focal serosal mass in the serosal mass. There is ascites, peritoneal spread, with multiple mesenteric and omental deposits, as well as a focal, eccentric, exophytic serosal deposit. So just to recapitulate the sonographic features of bowel disease, the site, gut findings, and perigut findings. In ulcerative colitis, the site is entire colon or left colon, including rectum, is involved. In ischemic colitis, descending colon is most commonly involved. Infectious colitis, right colon, ileocolitis is more common. In Crohn's disease, cecum, including terminalium, viscid lesions. Colorectal cancer are usually focal, short segmental focal lesions, localized lesions. Now, gut findings in ulcerative colitis, preserved stratification because the disease is superficial, involving mucosa only. In ischemic colitis, in initial stage, there can be preserved or there is loss of stratification. Infectious colitis, usually preserved stratification. In Crohn's, initially preserved. In chronic cases, there is loss. And colorectal cancers, colorectal malignancies, there is always loss of stratification. Perigut findings in ulcerative colitis, usually no perigut findings are present. Ischemic colitis, initially normal or there can be fat stranding in the later stage. Infectious colitis, thickening of the perigut fat and large lymph nodes may be present. Lymph nodes are shortly present, but perigut fat is usually initial stages not seen, but in later stages there can be. In Crohn's disease, always perigut thickening, fat and large lymph nodes, ascites, presence of abscess and fistula are present. In colorectal cancer, usually no fat perigut lesions are present, but sometimes we may see fat stranding in these patients. And in very complicated malignancies, we may see, fistulas. So I will not repeat the bowel findings in infection and inflammation. So these are neoplastic pathologies. Now let us have a couple of interesting cases, unknown cases. You please guess yourself and try to diagnose them. Please give me 1 minute. Now see, what is this? This is a 5 days neonate, premature neonate. This is gallbladder scan showing gallbladder wall edema, thickening, halo, internal echos, sludge echos, some cholesterol crystals showing cometal artifacts, right? Hyperemia, gallbladder wall, that is inflammatory. Liver shows multiple parenchymal bright foci. And when I see thoroughly the portal vein, I was able to see the multiple bright foci are coming along with the blood and seen within the branches of the portal vein. So these are air foci. Inflammation of gallbladder, sludge, portal venous gas, hepatic parenchymal gas. Bowel loops are, distorted wall pattern with intramural bright line, bright echoes, suggestive of pneumointestinal illness. So premature neonate, seriously ill, pneumointestinal is portal venous gas, associated cholecystitis, pneumohepatis, necrotizing enterocolitis, right? Female 25 years, pain abdomen, recurrent diarrhea, anemia. I am using transvaginal probe and viewing transabdominally. So small bowel loop distended with multiple internal structures. Round, 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 round. And on longitudinal plane, these are some trunk like structures, multiple structures. One ideal loop is distended and filled with these multiple stake-like structures, which are on longitudinal scans are long structures. So there can be single ascaris, as we have seen, and there can be multiple ascaris. As we can see, there is a fairly huge number of ascaris seen in the ideal loop, causing subacute obstruction sort of picture. Young man with pain and tenderness left iliac fossa, small fat lesion, inflamed fat just deep to the intra-abdominal, the abdominal wall. The sigmoid colon is normal, fairly large amount. No hyperemia, no fluid, nothing. Gut is normal. With severe tenderness, pain and tenderness. So it is epipleural appendicitis. This should be differentiated on left side from diverticulitis, where there is focal lesion with marked fat reaction around. So this is because of torsion of the appendage, epiploic. 32 male, tenderness right iliac fossa. See, tenderness. History of appendectomy 10 years back. Patient had appendectomy 10 years back. Now again developed acute pain and tenderness right iliac fossa. This is transverse and longitudinal scan of the cecum. This is cecum. This is a outpouching lesion. Small echogenic focal lesion with distal shadowing. Distal shadowing. Wall is thickened. Hyperemic. Fat reaction around. Patient had appendectomy 10 years back. Coming with pain and tenderness right iliac fossa. Raised leukocytosis. Raised CRP. 32 years of age. Ultrasound is sufficient for diagnosis, but the surgeon sent the patient for CT scan. These are axial and coronal images showing cecal wall thickening, this particular lesion with a small, this is fecalith, this is small fecal matter, this is fecal matter with inflammation all around. Cecal diverticulitis. Of course, diverticulars are common on left colon, but I have seen a couple of cases in which there is cecal diverticulitis. Even in pediatric patient, I have seen cecal diverticulitis. So fortunately, this patient is having history of appendectomy. Otherwise, clinically, there is strong suspicion of appendicitis. But sometimes you will not find appendicitis, but you will find diverticulitis of the cecum. So this is a case of cecal diverticulitis, post appendectomy status. Patient was treated conservatively and became all right. Female 67, chronic pain, weight loss, anemia, occult bleeding per rectum, altered bowel habits. Ascending colon, irregular thickening with some exophytic component, luminal narrowing. CT performed irregular wall thickening, short segmental, stenosing, slight fat standing, typical neoplastic focal stricture. Colonoscopy was done, biopsy was taken, and it turned out to be ascending adenocarcinoma of the ascending colon. Male child with pain, abdomen, vomiting, fever, clinically suspected to be appendicitis. This is the right hypochondrial scan. A rounded lesion with central echogenicity, typically giving an appearance of bowel in bowel appearance. Pseudo bowel in, I should say pseudo bowel in bowel appearance. So on longitudinal plane, this is liver, this is right kidney, this is Morrison space. The lesion is showing twisting. So in the longitudinal plane, there are 2 points, 2 rounded structures seen. Perilesional fat reaction, trace fluid. The wall of the lesion shows hyperemia. So these are not 2 structures. This is simple, same structure, which is curved, giving a false appearance of reduced It is not reduced. So it is a high place, subhepatic appendicitis, basically. So when you don't find appendix in right iliac fossa, always search for abnormal locations like pelvis, retrocecal, subhepatic, location. Subhepatic location is again common. When there is mobile cecum, it is high placed. 27-year male, chronic pain, abdomen, occasional vomiting, lumpish feel. Paramilical scan. Appears dilated bowel loop with some acquaintance, crescent sign, distal shadowing. Appearance like some bezoar or some large fecal matter mass, fecal matter filled bowel loop. But it is paramilical scan. It is small bowel. 27-year male. Chronic pain, occasional vomiting, means sometimes there is obstruction, subacute obstruction, and there is lumpish feel. So trace it. Trace the limit. The distal limit, there is thickening, gradual thickening, there is luminal narrowing, or at one end there is dilatation here, fecal matter loaded. Small bowel, fecal matter, small bowel is small bowel feces sign. On CT we can see. If you get CT of this patient done, you will find small bowel feces sign. With stricture, now see the stricture, there is a long stricture. Cut signature is altered, but muscularis propria is seen, serosa is seen, some mucosa is thickened. In the transverse plane, hyperemia is there. So this is the case of, again, Crohn's ileitis. Chronic case leading to proximal dilatation and subacute obstruction, presenting occasionally with subacute obstruction. This gives false impression of bezoar. 5-year male, बच्चा है, pain abdomen, vomiting, failure to gain weight, recurrent. There is intussusception, no doubt. Bowel in bowel appearance, mural hyperemia present, longitudinal A for sign. But on constant observation, at once time, I see some peristaltic movements within it. So this means the bowel loop is not very much, damaged. And child presented with vomiting and some sort of obstruction. So rest of the bowel loops are showing multiple intussusceptions. In the same patient, this was the largest intussusception. There were 3 more intussusceptions at various locations, 2 adjacently and 1 another. So these are transient intussusceptions, and this is well-formed pathologic organic intussusception, 5-year back. So patient is having recurrent pain abdomen, history of recurrent pain abdomen, vomiting, failure to gain weight. So there is a chronic, pathology leading to these ileo-ileal intussusceptions and ileocolic intussusception formation. The patient was subjected for TTG IgA test. It was found to be positive and turned out to be celiac disease. Right? So in celiac disease, basically intestinal involvement, mucosal involvement, loss of circular muscle folds, there is blunting, there is recurrent hyperperistalsis leading to intussusception formations, hyperplasia of the lymphoid tissue forming the intussusceptions. So TTG IgA positive, that's why it is a celiac disease. Otherwise, I have mentioned intussusception and formation of transient intussusception simultaneously, suggestive some chronic small bowel pathology. Please evaluate further. So it was found to be TTG positive celiac disease. Female 26-year anal pain and history of fever. So some anal pathology. Fever means there is some infective pathology. This is transverse view of anal canal. There is fistula. There is, see, this fistula at 6 o'clock, coursing the internal sphincter as well as external sphincter. There is formation of abscess posteriorly. This is abscess, horseshoe abscess in the ischianal space. There is internal opening. This is the internal opening. In the longitudinal plane, there is internal opening at the lower part of the anal canal. There is ischianal abscess. Transsphincteric in internal opening, transsphincteric in ischianal abscess. And there is no any external opening right now. So there is internal anal fistula with posterior ischianal abscess. This is how we can see in female patient, particularly with transvaginal route. Acute pediatric abdomen with vomiting. There is some obstruction. Pediatric patient, female patient uterus, some ascites in the pelvis full of internal echoes. Some infected ascites. Some bowel loops are dilated. Some are collapsed. Means there is zone of transition. On thorough examination, I could see there is small area of interloop thickening with small omental reaction, trace fluid, and extraluminal air. So this is a focal abnormal interloop area with fluid air suggestive of focal perforation with sealing. As I mentioned, when there is focal extraluminal air, means there is perforation with sealing. So there is interloop air, trapped air, omental reaction in the local area. This is the zone of transition, and there is formation of some dilated bowel loops, some are collapsed, leading to obstruction as well. So basically on ultrasound, what we can see is a focal peritonitis with omentitis extraluminary acidofocal pneumoperitoneum suggestive of some ileal perforation with peritonitis and adhesion causing small bowel obstruction. This is what we can predict by ultrasound evaluation of this patient. Again, zoomed images. This is air. So peroperatively, it was found to be very small metalls, which was perforated and sticked to the adjacent loop, and mental reaction. There was small adhesion and obstruction, leading to peritonitis and obstruction. So we have suspected a small perforation with sealing and peritonitis. So this was very tiny metals, with perforation and local peritonitis and adhesion and obstruction. So this is peroperative finding. So perforated metals with Meckel's diverticulitis with peritonitis and focal pneumoperitoneum. Thank you very much for your kind attention. Thank you. Over to you, Kartikeya or Chandni.
Thank you, sir. But we do have a lots of questions.
Okay.
You are taking the question, or Kartikeya sir will take? Hello.
Hello.
Should I
Dr.
take the
Kartikeya is there?
Yeah.
Hello.
Yes, sir, he is there.
So yeah, okay, I'll take up the questions.
So, Pairs patches are basically the valvular conjunctivitis, and in the late stages we see obliteration of the valvular conjunctivitis, whereas on the contrary, the ileum becomes more mucosal. So there is jejunization of the ileum sometimes, and blunting and paucity of the valvular conjunctivitis in jejunum. The reverse happens, and you will find small bowel always, showing hyperperistalsis, and sometimes you will see formation of transient intussusception. Bowel wall may be thick, may not be significantly thick. You may see hyperemia or grade 2 hyperemia is there, or sometimes not. You may see associated lymphadenopathy as well, or trace ascites. So these are the findings but we can suggest some small bowel pathology and suggest them to go for TTG, IgA antibody test.
Okay. So Dr. Sainath asked one of the questions on post-appendectomy complications, that how can we diagnose post-appendectomy complications like adhesions? And one more question regarding the stump appendicitis. How can we evaluate adhesions and stump appendicitis?
Okay. First of all, there is always history of appendectomy. The patient developed complications or symptoms due to complications after appendectomy. The immediate complications are, the give way of the sutures, and there is perforation and peritonitis, which you can diagnose by peritoneal, infected peritoneal fluid, adhesions, peritonitis, omenttitis, mesenteric thickening, septa, bowel loop matting. Another important complication is focal abscess formation, pericecal abscess formation, which you can see a fluid collection with internal echoes, focal air, focal pneumo, omenttitis associated local abscess, pericecal abscess. Another case, you can see fecal fistula. I have seen a couple of cases when there is focal abscess and there is a fecal fistula opening to the skin in the right iliac fossa. This is another way of another complication you can diagnose on ultrasound. And in cases of stump appendicitis, I have seen a couple of cases in they presented with pain iliac fossa, right iliac fossa. Thus only stump is seen, which is thickened hyperemic with perifocal fat reaction and local fluid, we can see, and some nodes. But there is history of appendectomy. It should be differentiated from cecal diverticula, and most commonly from cecal diverticula, or duplication cyst or Meckel's diverticula. But Meckel's is attached to ileum, not to cecum. And duplication cyst again is attached to ileum, not to cecum. So history of appendectomy, presence of a small gut lesion, amputated gut lesion with signs of inflammation suggests of stump appendicitis, right?
Yeah. One of the question from Dr. Naira is that how do you scan for retrocecal appendix?
The retrocecal appendix can be scanned from lateral approach or posterior approach. You can ask the patient to lie in a decubitus position, right side up, and you start your scanning from subhepatic area, lumbar area, scan the Morrison pouch, see the kidney. If it is high placed, it will be seen. If it is paracecal, it will be seen. If it is retrocecal, give slight posterior angle, shift the probe to posteriorly and see the inflamed appendix as a tubular lesion with perilesional fat reaction, fluid, and hyperemia. So there are lumbar approach, lateral approach, and posterior approach for retrocecal appendicitis.
Okay. One question from Dr. Gurdeep Chabra that he asked during the course of your lecture to show the Pearce patches, but I think you can tell where to see and how we can make out the Pearce patches.
Pearce patches are basically seen in the muscularis mucosa and submucosa. Normally, the loose areolar connective tissue and lymphoid tissue lying in that particular area. So whenever there is immune response and there is any insult, their immune system is excited, and there is the areas where the lymphoid tissue is present starts forming lymphoid cells in response to immune insult. And there is hypoechoic thickening of the mucosa and submucosa, in the terminal ileum particularly, and sometimes we can see lymphoid hyperplasia in appendix also. So, but most commonly the terminal ileum only. So these are seen as hypoechoic. The submucosa layer, which is normally seen as hyperechoic, white, it is seen as hypoechoic. And when you put color, these areas will be seen as hyperemia on Doppler, and you will see adjacent multiple mesenteric lymphadenopathy. So hypertrophy of patches make the terminal ileum very stiff, less peristaltic, and rigid. So whenever there is exaggerated peristalsis comes, sometime as a result of back pressure, it get invaginated within the cecum through IC junction and leads to form a intussusception. So these are that's why in majority of the patients of intussusception you will find hypertrophy of the patches and lymph node side, right?
Okay. One of the questions is regarding stomach evaluation, that sometimes stomach wall appears slightly thick, slightly thickened. So
Yes.
how to be sure of it being a gastritis? Is there any particular history that you
Yes,
get from the
history,
patient?
history. I have shown 3-4 cases today's lecture that history is very important. Pain upper abdomen, vomiting, pain after meals, typical history. And I have shown 3-4 cases. There is thickening of the gastric wall. There is mucosal edema. There is rugal edema. There is perigastric nodes present. There is hyperemia on. And most of these patients on endoscopy will reported as erosive gastritis. So history is again very important. Yes.
One question is that are mated bowel loops are features of tuberculosis?
Yes. It can be, it is feature of peritonitis. What may be the etiology? Acute perforation peritonitis, there can be matting. Chronic peritonitis because of chronic infection like TB, it can be matted.
Okay.
Or as a complication of Crohn's and all that, there can be matting. Matting is basically serosal thickening and sticking of bowel loops one another is matting because of the serositis and peritonitis. Serosal peritonitis, visceral peritonitis and parietal peritonitis.
Okay.
Yes.
Another question is in the same line, that how to differentiate between the wet, dry, and fibrotic type of TB on ultrasound, or will there be any clinical correlation, clinical presentation?
As I mentioned during my lecture, the TB causes abdominal TB is of different type. In pediatric patient, the presentation is different. In adult, the presentation is different. In pediatric patient, you will not find ileocecal tuberculosis. In pediatric patient, you will find mesenteric adenitis most common. And there is involvement of the peritonitis. When there is multiple tuberculomas are formed in the visceral peritoneum, parietal peritoneum, momentum, and serosa. And in wet TB, you will find more of ascites. And in elderly or adults, you will find ileocecal most common, bowel involvement with regional lymphadenopathy and its complication like strictures and small bowel obstruction. So in wet TB, there is usually ascites. There is involvement of the peritoneal cavity, the peritoneal membranes leading to ascites, bowel loop matting, omenttitis, mesenteritis, mesenteric lymphadenitis, sort of picture. In ileocecal, there is ileocecal involvement with nodes leading to obstruction. And sometime in pediatric patient, only ileocholic lymphadenopathy. So these are various type of involvement depending upon.
Okay. So one question is that you frequently get gaseous distension of bowel loops. This is seen in every third patient. Clinician
Yes.
wants us to write this finding. What is its significance?
If you are encountering gaseous bowel loops and which basically obscure your detailed evaluation, like you are not in position to evaluate mesentery or retroperitoneum clearly, then definitely you mentioned that there is gaseous bowel loops obscuring mesenteric and retroperitoneal details, because in the retroperitoneum there can be pathology, in the mesentery there can be pathology, there can be some focal area of bowel which is affected and you are not in position to get it because of the gaseous distension. So if it is significant, hampering and obscuring your details, you have to mention and advise the patient to re-examine after preparation or suggest them CT, definitely. But if it is okay, you are in position to get the details of mesentery and retroperitoneum, then you can mention nothing is significant, you can mention. And then some gaseous loops are present, but no any significant retroperitoneal or bowel pathology seen. If ascites is not present, lymph nodes are not present, bowel loops are not dilated, no bowel wall thickening is present, only gaseous bowel loops are present. If the consultant wants this thing, you can mention, otherwise it is not significant. But if it is pathological, you mention, suggest further evaluation after preparation or CT scan.
Okay. One question is that to demonstrate graded compression technique.
You just, because bowel contains air and fecal matter. So when you compress, the bowel will shift, the gas will shift, the fecal matter will shift, and bowel is compressible. These are the characteristic features of normal bowel. When it is pathological, wall thickening is there, it is non-compressible. So non-compressibility suggests some pathological bowel. So graded compression will make the bowel conspicuous to you for examination. If you don't see anything in the right iliac fossa, but you when make a graded compression, you suddenly come to see the appendix. But if you are loose and you are superficially examining, then you will miss appendicitis. So graded compression technique is a must technique to see the details basically. Otherwise, the abdomen hefty patient, you try to make a graded compression or make a compression to see, to bring the region of interest in view. So it is important to see the bowel characters, bowel wall details. So always use this technique in every area, whether it is LIF or RIF or epigastrium or pelvic area or any lumbar area, because otherwise you will not see. The anterior abdominal wall fat and some anterior small bowel loops are obscuring the details, retroperitoneal and deeper details. So always use graded compression technique.
Okay.
Graded compression. Yes.
What is the meaning of tubular target?
Tubular target means when you see the structure in transverse plane, it is seen as a target-like lesion. When you make the same structure in longitudinal plane for imaging, then you will see a tubular structure. So this word is usually used for appendix. Appendix seen as a tubular target tender lesion in right iliac fossa with mural hyperemia, thickening, peri lesion. It is attached to appendix. So tubular target lesion is used for appendix and or any other structure having a tubular appearance with gut signature.
Okay. The next question is by Dr. Shamila. In few cases, fluid-filled non-tender appendix is visualized without any abdominal pain. Diameter is more than 6 mm. Is it significant?
You just mention and forget it.
Okay.
You just mention it is 6.5 non-tender. No any evidence of secondary inflammation or no any evidence of inflammation are seen. If you don't mention, still it is okay. If it is not symptomatic.
Okay. So next question is in the same line that Dr. Shamal Patel asked, what is the difference between the appendicular abscess and the appendicular lump formation?
So what happens in uncomplicated appendicitis? There is a enlarged appendix. Wall is thick, more than 3 mm. And the cross-section diameter more than 6 mm. Wall shows hyperemia. When the infection or the inflammation spreads in all layers of the appendix wall, right from mucosa to serosa, then the fat reaction starts. Fat reaction around appendix suggests severe infection, which has extended beyond serosa. And it is basically attracting the omentum and the pericolonic or perianteric fat to limit it. When there is perforation, there is infection comes out of the appendix. There is local peritonitis, local abscess formation, but abdominal, omentum and mesentery and other fatty tissue try to limit it. So there is massive proliferation of the fat, massive fat stranding or massive inflammatory fat. Try to seal it, forming a lump. So when there is perforation, there is abscess. There is always surrounded by a fat reaction, forming a lump. So this is known as a lump. So this includes both abscess and marked significant fat reaction. So in earlier time, in past days, when there is lump, the surgery was avoided. But in the recent advanced era of equipments and techniques, every surgeon used to operate whether it is lump or not, because surgeons are more expert. These are experts, so they don't. The old surgeons give chance that first resolve it with antibiotic, then we will perform intraoral appendectomy. But most of the recent surgeons they do immediate surgery with fine techniques and all that. With the proper era of antibiotics, every surgeon used to perform surgery in the lump or even in abscess.
Okay. Sir, I would like to mention that we are left with 30 more questions.
Oh, then our time is, it's 9
Yes.
o'clock.
So
if rest of the question I will take tomorrow.
No, there is a complete list. We can stick to the concise way, so we can finish it off in time. So there is one question is that in RIF tender cases, sometimes normal appendix is seen. What could be the other possibilities? Mesenteric lymphadenitis, ileocolitis, typhlitis, epipleural appendicitis, sigmoid diverticulitis. There are a lot of possibilities. There can be pathology of the abdominal wall, endometriosis, abdominal wall abscess, any pathology in the right iliac fossa can cause tender. Okay. Next question is, in case of hepatic abscesses, periportal, peripancreatic lymph nodes are reactive. Some mention it as infective nodes. Which one is right way?
Now, you are supposed to mention lymphadenopathy. That's it. You don't mention it is infective. It's not the duty of radiologist to mention infective lymphadenopathy. We have to mention liver abscess with periportal and peripancreatic lymphadenopathy. That's it. If it is abscess, then they are definitely reactive and infective. There is no need to say about it. When to give stub appendicitis in case of post-appendectomy? When the stub is inflamed? When the stub is inflamed, exactly. Appendicular abscess and phlegmon, how to differentiate between them? I think phlegmon means it's an inflammatory mass because of the fat, inflamed fat. The amount of the fluid is less. It is more of a phlegmon. It needs antibiotics. And abscess means there is more fluid with internally caused debris, gas-forming bacteria. There is local pneumoperitoneum. It needs to be drained immediately. So, and on compression technique, the fluid abscess is compressed, but the phlegmon is non-compressible, less compressible. Okay. Next question is that patient with a history of diarrhea with normal appendix, when initially examined, on the follow-up next day, inflamed appendix is seen. Is it possible or something has been missed out during the initial scans? No. If you have thoroughly examined in the initial scan, you find normal appendix, all right. After 24 hours, there can be chances of inflammation. Everything happens in medical science. Anything can happen. Yes. I think one should examine from the root of the base of the appendix till the tip. So there is a very good chance if you might have missed the tip appendicitis and it has been increased today. Yes. Coming to the next question, if perforated appendix, sometimes mucosal discontinuity is not appreciated. There is no need. Perisical abscess or it indicates perforated appendicitis because the infection has spread beyond the lumen of the appendix. So there is local peritonitis and local abscess formation. So presence of abscess in RIF indicates, and it is an indirect sign of perforated appendicitis. Okay. I have showed a couple of examples today only. Dr. Shivangi asks one of the questions that are edematous and inflamed wall both are same? If different, how then we differentiate? Inflammation, when there is hyperemia, the inflammation word is better. Otherwise, you can thick and edematous. If wall is hyperemic, you can add this word inflammation.
I think your Doppler will let you
Ah.
know that it is inflamed or it is thickened. Coming to the next question, in cases of the rectal diverticulitis, without any perirectal fat stranding, only outpouching is seen. Can we give as diverticulitis?
I have not seen any case of rectal diverticulitis. Sigmoid diverticulitis, it's okay. Descending colonic diverticulitis, it's okay. I have not seen rectal diverticulitis. But the diverticulitis means diverticulitis, anywhere it is. The findings will be same.
Yes, the question is without inflammation. I think that will be
normal diverticulitis. I've shown couple of cases of normal diverticulitis. Normal diverticulitis is just echogenic outpouching without any sign of inflammation or fat stranding or fat reaction. That's it.
The correct term will be diverticulosis.
Diverticulosis. If
Yes,
the number, okay. Sometimes you see normally multiple diverticulars. So I mentioned sigmoid diverticulosis is present, no any inflamed diverticular form. That's it. Because any day there can be diverticulitis. Diverticulosis is better term to use for normal diverticulitis. Yes.
One question is that meaning of cross-section diameter, is it short or the long axis in cases of lymph node? I think short axis we are
Short
talking
axis
about.
is more important. Shape is more important. Vascularity is more important.
One
Yes.
of the question by Dr. Shamil Patel in regard of Meckel's, that how to identify the antimesenteric border.
Meckel's is always situated at antimesenteric border. It is very difficult. It is a theoretical part. That duplication cysts are usually seen on mesenteric border and diverticulars are seen on antimesenteric borders. So when Meckel's is present, it is always on antimesenteric border. And duplication cyst is considered to be on antimesenteric border. And in CT, we can sometimes better appreciate the mesenteric and antimesenteric, because we can have a cross-section imaging, 3D imaging. So we can have in cross-sections in every direction. So CT is better modality, but on ultrasound, sometimes we can appreciate and sometimes we cannot say. But Meckel's is always antimesenteric and duplication cysts are always mesenteric.
Okay, so one of the Dr. Arnab is saying that he liked the lecture and he is very much appreciating that this is his favorite topic. And he asked the question that what are the common sites for ectopic appendix? How to differentiate between the ectopic appendix and the Meckel's diverticulum? Ectopic
appendix is always situated to the cecum. There is nothing like abnormal. You can see abnormal location means it can be retrocecal, which is rare, which is most common is ileal, pre-ileal or retroileal condition is very common. But sometimes it is seen retrocecal, it is abnormal location. Sometimes it is mobile cecum and it is in subhepatic. So it is a high place appendix. Sometimes it is seen parallel to the cecum and ascending colon on lumbar side, it is a paracecal. Sometimes cecum is long and we cannot see appendix just at the base and then it dips in pelvis. And there is no any window to see the pelvic appendix on abdominal approach. So it is very difficult to see, pelvic appendicitis. In female, you can use transvaginal route. So if pelvic appendicitis is again abnormal location. Sometimes it is, seen on left iliac fossa in cases of midgut malrotation. I have seen a couple of examples. I have seen a couple of cases in which the appendix was seen in the left iliac fossa. And I examined the mesentery and alignment of the mesenteric vessel, and I found there was a transposition of the SMA and SMV, and the patient was having midgut malrotation and malposition. And I have seen appendix in left upper abdomen, one case. And in that case, there was a midgut malposition, again midgut malrotation. So when there is midgut malrotation, appendix can be seen on left side. Or in the situs inversus, when there is total anomalous position, then you can see appendix in the left side. Otherwise, appendix is seen always in right side at various locations like subhepatic, retrocecal, paracecal, pelvic. These are the abnormal locations. Right?
Yes. So one question is that gangrenous appendix and pyogenic liver abscess. Is there any connection between them?
I have showed one case. Gangrenous means that there is no vascularity. So it was, it is severe badly, gangrenous appendix. But at the same time, the patient was having multiple abscesses. So it was infected by the pyogenic bacteria, and that has gone to the liver via portal circulation, lead to multiple liver abscess formation. And incidentally, the appendix was found to be gangrenous on ultrasound. That's why. So gangrenous means there is vascular compromise. So gangrenous appendix is prone for rupture.
Okay. So one question is regarding anorectal cases that you showed, that please give us the list of the clinical presentation related to the region of interest, like you told for the painful defecation. Likely the cause will be the anorectal disease. I don't know what's the question in it.
What is the question?
So I'll just dismiss this for a while. Next question, in one of the last cases, infection/inflammation on that particular image, how do you differentiate between the abscess and the fistula? I think the anorectal one.
Initial, there is occlusion of the anal glands. So there is formation of abscess in the intersphincteric plane, number one. This is the basic initial pathology in the rectum. There are anal glands which secrete mucus to make it wet all the time. When there is obstruction of the anal gland, there is formation of retention cyst, and infection happens. There is formation of small abscess in the intersphincteric plane, because these glands are lying in intersphincteric plane. When the abscess increases and there is erosion and local pathology extends, this will erode the external sphincter. So initially there is intersphincteric abscess causing painful defecation with internal opening in the anal canal. then it erodes the external sphincter and reaches beyond the anal canal in the ischioanal or ischiorectal space, forming an abscess. Then it is abscess, having internal opening. And in some situation, when there is external opening also, the abscess erodes the soft tissue planes in the perineum and comes out at an external opening through an external opening in the perineal area at various locations, giving a fistula formation. So initially, always there is abscess with internal opening in the anal canal, and in fistula formation, there is external opening also. Then you have to assess the fistula. What is the nature of the fistula? Whether it is a primary tract or whether there are secondary tract also. Number of external openings, their course, their length, and all parameters should be mentioned. Right?
Okay. So one question is difference between altered stratification from the loss of stratification. I think the question itself is the answer.
Yes. Altered means altered, lost.
Yes.
These are, sequential terms. Initial, there is normal pattern is signature sign, gut signature. It is blurred. It is seen, but it is not very clear. The line demarcation is not clear. It is blurred. It is subtle altered. It is slightly altered. Then there is loss. When there is stratification, is completely lost. That's it. There is blurring and lost. There are two terms.
Okay. What are the ultrasound features that favor USG guided hydrodissection in cases of intussusceptions?
What is the question?
USG features in which are in favor of sending the patient for hydrostatic reduction in intussusceptions.
Yes, uncomplicated intussusception. Like when there is no ascites, there is no sign of peritonitis, no significant dilated bowel loops, bowel wall vascularity is preserved, and short history. These are intussusception is small sized, less than 3 centimeter or it is 3 centimeter. When it is complicated means the bowel, the trapped wall is showing massive edema, poor vascularity, fluid within the bowel layers, presence of ascites, and pneumoperitoneum are contraindications. Right?
Okay. Next question is what should be the PRF settings while evaluating the bowel?
It should be kept low PRF. You first see the settings, then gradually reduce the PRF, gradually increase the gain, and you try to see. You apply the color Doppler criteria. There is nothing like it. There is no significant velocity I will mention. Mention accordingly. Usually it is low flow settings. You keep less than 10 centimeter per second. Sometimes 5 centimeter per second.
Okay. One of the question is that in thin patients, do we normally see the sawtooth appearance of small bowel?
Sawtooth appearance? What do you mean?
I don't know. It's just in the question.
Jejunal bowel loops are showing circular muscle folds. They're known as vulvally conventives. So jejunal muscle mucosal folds are seen as vulvally conventives. Ileal loops are characterless. Colony showing postural. These are various patterns. I have not mentioned any sawtooth appearance.
Okay. Coming to the next question is that why lumen remains dilated in cases of lymphoma?
I mentioned during my lecture, there is infiltration of the meyenteric plexus or the nerve plexus, which is situated in the muscularis mucosa and your muscularis propria. So this infiltrates, destroy the nerve fibers. So there is basically circular muscle activity or the peristaltic activity is basically reduced. So that the gut remain dilated, because of destruction of the meyenteric and the meyenteric nerve plexus.
Okay. How do you identify ulcer in duodenum or in bowel loops? I think this was very well explained in all the ulcer craters that you have shown. Yes. Difference between Crohn's and infectious colitis of terminal lumen. I think this has been mentioned in the lecture. Yes, this is one of the questions that what does cholesterol crystal inside the GB lumen suggest? Are these calculi only?
These are crystals. These are not calculi.
I think
the sludge, they are basically sludge. Sometimes we see cholesterol crystals, sometimes we see just calcific debris. So these are all sludge part. They resolve by itself after some time.
But there is one of the pathologies that when we see the crystals in the lumen of the GB lumen. Yes, adenomyomatosis.
That is seen in adults. Today I shown that patient was premature neonate. So that was incidentally showing cholecystitis and stagnancy of the bile, leading to the visibility of these crystals and sludge. So this suggests bile stagnancy, basically altered bile with stagnant bile, because pathological gallbladder is stagnant.
Okay. So we are left with the 3 questions. Differentiate primary appendicitis with inflamed terminal ileal loops versus secondary appendicitis. Secondary means it is associated with ileocolitis, which is a primary pathology. So these patients are not to be subjected for surgery. It will resolve by itself after resolution of the ileocolitis. So when ileocolitis is primary pathology, as an appendix is also seen inflamed, you mentioned ileocolitis with associated appendicitis. And if ileocolitis is not there, it is isolated appendicitis, it is always a surgical case. Okay, so one question is that normal bowel loop shows vascular flow on color Doppler. Can we pick it up by the linear probe?
No. Usually we don't see. Usually we don't see, but at today's era we are having nice equipment, microvascular imaging, so we can pick up even in normal blood. Okay. In recent advanced machines, we can pick up. No.
One of the attendees asking that kindly demonstrate the graded compression technique tomorrow for the appendix or any other pathology.
But there is nothing to demonstrate. You just put pressure to the probe to displace the
Ga-
fat, displace the gas, and to bring the structure proximal to the probe. That is the main criteria. There is nothing like demonstration. You just make compression, compress the probe so that you can reach the region of interest, and you can see the region of interest as per your focal point.
Okay,
That is the-
so we have finished with the questions, but there are a few requests. Dr. Shamal Patel is asking, kindly prepare a lecture on the neonates with the abdominal USG techniques.
Tomorrow we will show you, pediatric abdomen. Tomorrow will be more of pediatric because developmental pathologies of the bowel are seen only in pediatric age. So tomorrow you will enjoy the talk.
Okay,
So tomorrow will be the pediatric day.
that will be great. Dr. Sakshi is asking that there are certain common clinical presentations with various associated disease that in one of the finding that you told that postprandial pain is associated with the gastric ulcers. So she's asking, can you more elaborate in the coming lecture with these kind of clinical presentations, the list of such kind of things?
Postprandial means pain after meal. It
No,
will involve basically gastric pathology or mesenteric ischemia. There are two important conditions. In
Yes, sir.
duodenal ulcer, the pain will be subsided after meal. In gastric pathology, pain is after meal, and there is fear to food is seen in chronic mesenteric ischemia.
No, the basic thing she's asking that the way you told that postprandial is associated with the gastric ulcers, so kindly elaborate such kind of clinical presentations in the subsequent lecture.
Okay.
So he's just asking for the list of such kind of clinical presentations that you usually see while evaluating for the bowel diseases. I think we have finished with all the questions.
Right. Okay. Thank you.
Okay, so with this, it's been 3.5 hours, and we can conclude with the session. Over to the host of Mediflec.
Thank you, Dr. Karthikeya, for helping us, for your support. Thank you, Dr. Subhash, for delivering such a wonderful lecture.
Thank you.
Thank you, sir, for answering all the questions. Thank you, Dr. Karthikeya, sir, for taking all the questions. Thank you.
Thank you very much.
completed
Yes,
Wonderful session. Thank you, sir.
thank you.
Thank you.
Good night,
Thank
everyone.
you, Dr. Karthikeya, for
Good night,
joining us.
everyone. Thank you.